Dr. Chitresh Agarwal. He is a senior consultant, medical oncology and hemato-oncology at Paras Hospital, Panchkula, and Agarwal Cancer and Care Diagnostic Center, Panchkula, for the welcome and introductory note. It's over to you, sir.
Thank you, Nishant. I welcome all of you on the day 2 of clinical updates on common cancers. So, yesterday we had discussed primarily on breast cancer and lung cancer. Today we are going to start this, session by starting and discussing on GI cancers. And to start today's academic feast, I would request respected Dr. Javed Muzammil, who is a consultant at Government Medical College, Srinagar, and he will be talking on immunotherapy for colorectal cancer. So, thank you, Dr. Javed, for accepting the invitation, and I welcome you. And please, give your talk on immunotherapy approaches for CRC. Welcome.
Thank you, Dr. Chitresh Agarwal. Thank you in giving me opportunity, and I thank all the organizers which are involved in this meeting. So my topic will be the immunotherapy approach in CRC. As we see, immunotherapy is evolving, and the evolution of immunotherapy is also in colorectal cancer. Now, earlier it was in deficient, MMR deficient. Now you will see in another 10 to 15 minutes that we have in MSS patients, I mean stable, stable patients as well. So as we see that colorectal cancer, we see all the 4 phases as patients can have advanced MSI high, they can have advanced, but the disease is advanced, but no MSI high, there is MSI stable. Then comes the early stage or local regional disease patients having MSI high and MSI low. So I'll be discussing all the 4 things. So it was an earlier paper that was published in NEGM 2015 by Lee, and she actually analyzed it in that in one of the clinical data that in MMR deficient patients you are seeing complete these partial responses, stable disease, but you are not seeing good disease control in MSS patients. So that was a hypothesis which has been tried in different trials. So let us look back to some of these studies which have been done in advanced colorectal cancer patients in who have received earlier lines of treatment. So it is more than one line of treatment that has been given, and now patients are subjected to immune checkpoint inhibitors. One of the study is Keynote 164, where the pembrolizumab was used, and you can see in this trial there has been consistent objective response rate to anti-PD-1 therapy. And if you look at this graph, more shrinkages, but there are some progressions as well. We will discuss that why there has been progressions in this study. Then came the Checkmate 142. In the Checkmate 142, where you can see there has been a Nivo versus Nivo AP in MSI high patients. And here you can see that those patients who received dual immune checkpoint inhibitors, there is more shrinkage, more CRs, more PRs, more stable disease than progressions. And the benefit, if we see benefit from these immune checkpoint inhibitor trials, if you look at the PFS data in Nivo APR, that Checkmate 142, at 4 years, almost we see 53% of patients have no progression. So it has not reached, median has not reached. And if you look at the overall survival on the right side of the Kaplan-Meier curve, that at 4 years, 70% of the patients were alive. And the 6-year update of this study, which was presented in ASCO GI 2024, 67% of patients were alive. And you can see the more you follow, the more will be the overall survival benefit. And this curve is almost, it is now plateau. It is just running parallel to the baseline. Now there are some phase 3 trials which has been done in metastatic patients. One of them is Keynote 177, which is now the first line trial. They were the second line trial, so it's a first line trial. And the patient enrollment were the MSI high patients, stage 4 disease, and ECOG performance 0 or 1, and with measurable disease. The randomization was between investigator choice of chemotherapy versus Pembro for 2 years, giving 200 milligrams every 3 weekly. But here the crossover was permitted on progression. If chemotherapy patients they progressed, so crossover was permitted. So if you look at the 24 months progression-free survival, and here we can see median PFS is double because of the immunotherapy versus chemotherapy. So it is 8.2 versus 16.5. 48% of patients had no progression in Pembro arm. Then the second, if you look at the overall survival from this Keynote 177, and you can see at 3 years that overall survival, median overall survival has not been reached in Pembro arm versus chemodialysis. It was around 3 years, 36 months. So it is 61% of patients had no progression, had overall survival benefit versus 50% in chemotherapy. And the data was statistically significant with hazard ratio of 0.74. Then there is another study that has been done in MSI high patients in a first line setting having MSI high. So here the stratification was again done on the basis of whether patients had received early lines of treatment or not, and patients, what was the sidedness? It was the left-sided or right-sided disease. So this data was presented in ASCO GI 24. It is Checkmate 8 HW. So the randomization was 2:2:1 into Nivo versus Nivo EP versus investigator choice of chemotherapy, whether FOLFOX or FOLFIRI with biological agent, depends upon the sidedness. Bevacizumab on the right side and Stuximab on the left side. So Nivo was given as 6 doses, 2 weekly, and then followed by as a maintenance 4 weekly for 80 milligrams for 2 years. And but EP was given only 4 doses, and rest was given as maintenance in Nivo EP as a Nivo maintenance. The primary endpoint here was the PFS by this blinded independent reviewer in the Nivo EP versus chemo. Then another PFS was from the Nivo EP versus Nivo. So there was a comparison between Nivo EP versus chemo, Nivo EP versus Nivo. And the data cutoff was October 23, and which was around 24.3 months. And if you look at the primary endpoint interim PFS analysis in Neo EP versus chemotherapy, almost there is no comparison. At 24 months, you can see 72% of patients had no progression in Neo EP arm versus 14% in chemotherapy arm. And if you see hazard ratio is 0.21, which is statistically significant. So there was a very good benefit by giving first line Neo-EP in MSI high patients. And this is supported by the guideline also. NCCN also endorses the same thing, unresectable synchronous liver or lung metastasis patients. So one of the first line is Nivo-EP or Pembro if there is MMR high or MSI high. Then there are some questions which we need to ask to ourselves that in Pembro or this trial, Keynote 164, there were some 30% progressions with monotherapy. Why it was there that all the immunotherapy trials are showing response, why there were early progressions? Possible reasons could be that it might be false MMR status, maybe it was zero progression, or maybe those patients had low tumor mutational burden or some other mutations associated. Now, another question is similar that in case as we see in the lung trials also, immunotherapy does not work in patients who have targetable mutations like EGFR, ALK, and ROS. But it has been seen in dual immunotherapy once you use Nivo-EP in lung, as we have Checkmate 214. So there you can see 227, Checkmate 227. You can see that patients who had RAS mutation or P53 mutation, KEAP mutation, they had better benefit with Nivo-EP. But similarly, if you see here RAS mutation giving rise to resistance to immunotherapy in Keynote 164. And you can see the Foster plot. Those patients who had a RAS mutation, they did not do well versus those who had a wild type. But if you look the same question in Checkmate 142, which was published in JCO 2022, and here you can see patients having the RAS mutation around 24-month PFS was 87%. We can say 85%. So for BRAF mutation, it was around 75%. If both were wild type, it was around 65%. So there is 10%, roughly 10% drop if patient had mutation, if patient did not have. So mutations, those patients who had mutation, they did better than those who had wild type, these mutations. And you can see this is a contrast to previous trial, which I shown here, Keynote 164, where the mutations played a bad prognostic factor. Now about the Checkmate 8H4, which is the new trial in the first line setting. So it is irrespective of the mutation, whether the RAS, RAF, or co-mutations were present or wild type, they had a benefit. But the best benefit was seen in patients who had all RAS, RAF, wild type. And you can see the Foster plot, the pointer is away from that of the unity, but it was irrespective of mutations. The benefit was seen in all patients. So similarly, do we need to give dual immunotherapy versus single versus, that is Nivo EP versus EP, Nivo EP versus Nivo? And you have seen that there are some early progressors, and there are some mutations which are not being tackled by the single agent immunotherapy. So it is always better to give dual immunotherapy if uh, uh, things are good for that patient, if you can challenge them with the dual immunotherapy. Then the fourth question is that in patients who have a Lynch syndrome, other syndromic manifestation, because they are prone to get more and more second cancers, is immunotherapy playing some role? If you see here, yes, in these patients, it has been seen that in the immunotherapy era, that skin cancers are having increasing incidence if patients has been exposed to immune checkpoint inhibitors. But as far as the visceral cancers are concerned, like we have linked in endometrium, stomach, hepatobiliary, those cancers are taking backseat. So those cancers are decreasing. So in post immune checkpoint inhibitor, those patients, they do not get more visceral cancers than they were earlier getting. Now, this was about the MSI high patients. What about the MSS metastatic colorectal cancer patients? So we have some studies like RigoNevo, which was published in 2020, and we have a LEAP. In RigoNevo, we use regorafenib and nivolumab, and in LEAP, we use pembrolizumab and lenvatinib. So you have to combine here with the TKIs to get the better response. And here you can see in these two graphs that in colorectal and the gastric cancer, more partial responses, more stable diseases than the progressive disease in RigoNevo or the LEAP study. And here, progressive diseases you see very less than stable and the partial responses. So this is one of the interesting studies, but only one thing was seen there. Those patients who had liver metastasis, they had virtually zero response, while patients with non-liver metastasis had response to the tune of 30 to 35%. Microenvironment also plays a very important role where there is a metastasis, whether the metastasis are in the lung, whether liver, whether there is other colorectal metastasis, or there is a peritoneal disease. Because of the, you see the B cell infiltration, macrophage infiltration, then the immune checkpoint effector pathways like CD8 infiltration, they play important role. Then we have another study in MSS patients, that what is Maya study, Maya trial. It is done in those patients where the MSI is stable and those who have MGMT deficiency, as same we do in the glioblastoma. So here the patients receive temozolomide followed by combination with the low dose EP-Nivo. And you are seeing this from the Maya study. There are some CRs, very good PRs, and some stable diseases and less of the progressive diseases. Now, what is there for the MSI high but early patients, early locoregional disease, and the studies started coming from the Mariam Chalabi 2020 from the Niche One trial, and if you see from that study, she had included both proficient as well as deficient. The green blocks are proficient patients, while the red blocks are MMR deficient patients. And you can see in early stage CRCs, you are seeing a lot of CRs, and there are some proficient patients you are seeing now three CRs in this study as well. So NeoEP is working in this group of patients as well. So then she did another study, Niche 2, 2022, and she actually wanted to see what was the pathological response. So she divided them into major, complete, and partial responses. Major responses, she said that once there are only less than 10% residual viable tumor cells, complete response is 0% of the tumor cells present in the surgical specimen, partial is 10 to 50% are the tumor cells in the surgical specimen. And here she could see that with a median follow of 13.1 month, there has been no disease recurrence in that group of patients. And you are seeing CRs and PRs and in this study. So one of the because there was a lot of noise that was made by this study, which was presented in ASCO 2022, that PD-1 blockade as a curative intent therapy in MMR deficient locally advanced rectal cancer. So it was an AZURE 1 study. Only 23 patients were included, where dostarlimab was given as 500 milligram every 3 weekly for 6 months, total 8 doses. Then radiological endoscopic assessment was done, and those patients who had complete response, they were put for the non-operative follow-up. And if you see from that study, 100% of patients achieved complete clinical response, and all the patients did not receive any kind of further treatment, whether RT or chemoradiotherapy or surgery. So this is then another study was done, which is actually this time on run, and this is AZURE 2, and here the patients have been enrolled, and one of the study group will receive dostarlimab 4 doses, followed by surgery, followed by another 4 doses, and put them on follow-up. And in the standard arm, patient will get surgery, followed by adjuvant chemoradiotherapy. Then the patients will be on follow-up. So we may get this study. It will take still a long time to get it completed. Almost we have 711 participants in this trial. So this NCCN endorses immunotherapy in MSI high patients as well. So you can see those who have a local regional disease in neoadjuvant setting, you have dostarlimab or NeoEP followed by reevaluation. If a patient gets complete clinical response, put the patient on cellular. So there are now non-operative measures in such patients. So what is there for MSS patients? That's MSI low, or microsatellite stable patients, which are early colorectal cancer. So from the same study as Mariam Chalabi did in 2020, and there were some patients who had MSS proficient, that's DMM. They were not DMMR, they were proficient MMR. And you can see the green blocks. The 3 patients achieved uh, complete pathological response, and there were few partial responses as well, and there was no progressive disease. There is another study, that is Tarzan study, and this was presented in ASCO 24, where in patients who had lower intermediate risk rectal cancer, non-metastatic, where you could give 5 fractions of the radiotherapy in 5 days with 5 grays each fraction, so that the tumor becomes immunogenic. Then start with the bevacizumab, give 3 doses of bevacizumab with 3 doses of atezolizumab, and evaluate the patient at 12 weeks with the CT scan, MRI, and endoscopies. And what they have seen at 12 weeks, 56% of patients had near clinical CR, and organ preservation was done in almost all patients. 4 out of 9 patients underwent local excision only, and 5 out of 9 patients achieved organ preservation without additional intervention. So this is again encouraging that in a MSS patients, early stage patients, you can give neoadjuvant chemo and with anti-VEGF therapy, this immune checkpoint inhibitors and anti-VEGF therapy. So there is another study, that is next one, and which is again presented in the ASCO 24, where immune checkpoint inhibitors in the form of botensilimab, which is basically anti-CTLA, and another drug which is balstilimab, which is PD-L1 inhibitor. So again, this was given similarly as NEO-EP and followed by surgery. So you can see top line results of this study. They were all here MSS, which are dark green patients, and 2 patients achieved complete response, and 2 patients achieved very good partial response, and 3 patients achieved partial response. And you see stable disease was seen in 1 patient, and only there were no patients who progressed. So that's the highlights of this study. So to conclude, immunotherapy in uh, colorectal cancer, whether it was metastatic or locally advanced, in case of microsatellite unstable patients, like MSI high patients, immune checkpoint blockade is indispensable. Preferably, one should use in the first line. So NEO-EP is scoring over single agent immunotherapy to tackle early progressive diseases, and immune checkpoint inhibitors with TKIs, whether in Rigonivo or Pembrolizumab, it's a LEAP trial, may be considered for MSS non-liver metastatic CRC setting, and neoadjuvant immune checkpoint monotherapy is an attractive option for localized MSI high colorectal cancers, and we have NCCN endorsement also. All patients must be screened for MSI at the beginning only. So I am convinced, and later on we will have more and more clinical data that will be available in MSI high MSS patients, how to tackle them in the early stage cancer in colorectal cancer patients. Thank you very much.
Thank you, Dr. Muzammil. Thank you for a nice talk. So I would just like to know from you that how is your practical experience with the pembrolizumab or immune checkpoint inhibitors in MSI high patients?
I do use in so far metastatic patients. I have not used it for the early, yeah, as they are saying, colorectal cancer patients, but I have used it in the very few patients in metastatic. Very good results. Very good results. Even those patients did not receive no chemotherapy so far. There was some toxicity, and I have to drop down the dose also from 200 to 100. And in one of the patient, I am giving 40 milligrams only nivolumab. That response has been, exceptional.
Thank you. Thank you. I thank you for a wonderful talk. So moving on to the uh, next session, I would request the tech team to allow me to share the screen for the panel discussion on HCC. And I would request my panelists, Dr. Mukesh, Dr. Priyanshu, and Dr. Kanika, to please join. Dr. Priyanshu is a medical oncologist at IVY Hospital, Mohali. Sorry, now it is Livasa Hospital, Mohali. And Dr. Mukesh is at Alchemist Hospital, and Dr. Kanika is at Max. So, this is a discussion on hepatocellular carcinoma and choosing the first line immunotherapy in advanced inoperable HCC in 2024. So, what is the definition of advanced unresectable HCC? So, any patient who has a stage 4 disease or a patient who has, portal invasion, extrahepatic spread, preserved liver function, they go for systemic therapy directly and are technically inoperable. And for some intermediate stage B patients who have a multinodular involvement, preserved liver function and a performance status which is preserved, chemoembolization could be one of the options. But most of the patients, they land up either with advanced stage C or D, where we offer either systemic therapies alone, or we offer best supportive care for most of the patients who land up in hepatocellular carcinoma in our clinical OPDs. So this is a 55-year-old person, known case of CLD, and he is HbA1c positive. He is on therapy for HbA1c. He complained of abdominal pain. He was evaluated. A CT scan was done, which was suggestive of large liver lesion, and it also had multiple other lesions in the other lobe, multiple precaval and portal nodes. He had a high AFP value, and no comorbidities were seen. So I would like to start with Dr. Mukesh. So what would be your line of management now? What will you do next?
Sir, if the patient has the financial viability, then I will go for upper GI endoscopy to rule out varices and then start with atezolizumab plus bevacizumab.
So will you do a PET CT scan? Will you do a biopsy, or this information is enough?
I hope the CT chest and abdomen has been done. If it has been done, then it's okay. If it is only CT abdomen, then we can go either for CT chest or whole body PET CT scan. Biopsy, I think, is not required because patient is high risk because of chronic liver disease, cirrhosis is there, and AFP you have mentioned is high. If the CT scan triple phase is typical of the SCC, the arterial enhancement and venous washout is there, I see no need for biopsy in this case.
Correct. So I think elevated AFP, characteristic imaging findings on a triphasic CT scan would label this gentleman in the backdrop of a HbA1c positive CLD cirrhosis to be a case of hepatocellular carcinoma. My two other panelists, they would like to do some other investigations, or this is enough for you also, Dr. Priyanshu and Dr. Kanika?
Viral load for FP
Yeah.
and I
Upper
guess
GI
CT is
endoscopy.
endoscopy and CT. I hope it is a triple phase.
So correct. So I think upper GI endoscopy will be an important, investigation in this. Why? Because we should be able to know the varices, and we should be able to, sometimes evaluate the status before contemplating systemic therapies. So what would be your, treatment plan, Dr. Kanika?
So if the upper GI is normal and the patient have no bleeding manifestations and cost is not an issue, then first line atezolizumab bev combination.
Okay, so atezo plus bev is your choice,
Yes,
and so correct. So we know as of now that
No,
the era is
we
of.
don't have a child pug scoring.
So child pug is okay. So child pug would be, say, you take two scenarios, one where it is A, another where it is C. So how would you decide?
Definitely you cannot give in C. C usually would, I would say, best supportive care, or at the most you can give sorafenib. That is what is. But it's B.
So I think there is some disturbance, Dr. Priyanshu. I couldn't make out on that point. But I think
Yeah,
he has made up.
B7, B till B7 it is.
Yeah, so depending on the child pug status, we have to ascertain the therapy lines. And any patient who comes in child pug C would definitely not be candidate for these therapies. Till B7, we can consider atezo plus bev combination. So this is the era of magical duo where we are using IOs with TKIs. So we have evidence of, a combination of Nivo EP. We have the combination of atezo-bev. We have the combination like these which are working in HCC. So this is the 4-year-old survival data from the phase 3 Himalaya study of tremelimumab plus durvalumab in unresectable HCC. Then we have Lemna plus Pembro, and then we have Nivo EP which was the latest entrant in this field. Now, we have to be always watchful of this fact that when these studies are done, the comparator arm is not the standard of care, but predominantly it has always been sorafenib. And only with pembrolizumab it has been, the comparator arm has been lenvatinib. So when we see the evidence of lenvatinib versus sorafenib, we will see here that the PFS was 7.4 months versus 3.7 months. And the overall response rate was high with lenvatinib 24.2 months versus 9.2 months. And the overall survival was 13.6 months versus 12.3 months. When we see the comparison of atezo-bev versus sorafenib, the PFS was again better with the combo of atezo plus bev, where it had 6.8 months versus 4.3 months. Overall response rates were high, and the overall survival was also significantly longer, with atezo-bev 19.2 months versus 13.4 months. Now, the latest data of Himalaya, the Tremi plus, Durva, again, the response rates are 20.1% versus 5.1%. Overall survival 16.4 versus 13.8 months. And toxicity was also relatively similar. So what these trials are showing us that sorafenib, there are better therapies available in comparison to sorafenib. But how will these therapies favor or fare up when these are compared with lenvatinib, that is the other standard of care, who are patients who are not able to afford the IO-TKI combinations? Yet we do not know yet. It would be a cross-trial comparison, but it has never been studied in a randomized fashion. So this is the safety and efficacy of atezo plus bev in real world, the first Indian experience which was published. And it shows that, patients have had a clinical, partial and a stable disease response rates with this composition. And many of these patients actually benefit when we use this combination. So how did this, evidence come from? This came from the IM-BRAVE 150 study, where locally advanced or metastatic HCC with no prior systemic therapies, they were randomized to atezolizumab 1200 milligrams IV Q3 weekly, plus bevacizumab 15 mg per kg, or to sorafenib 400 milligrams BID. And this trial included high-risk patients in the form of invasion of the main portal vein, bile duct, and more than 50% of the liver occupying the tumor. And the stratification also had a baseline AFP of less than equal to 400 or more than equal to 400. So what we saw here was that in updated PFS, atezo plus bev had a median PFS was 6.9 months, and sorafenib had 4.3 months, and the hazard ratio was 0.65. And for the updated OS, we would see here that, as I previously mentioned, the median OS was 19.2 months versus 13.4 months, and the stratified hazard ratio was 0.66. So in a known case of HCC, the present PET scan was done, which was, this is some other data. I think there is a slight confusion above and down. So patient was started on, atezo plus bev, and post 4 cycles, patient had ascites, insomnia, elevated OTPT bilirubin, AFP was same. So what to do next? Dr. Mukesh?
Sir, in this case, I will go for a imaging. If it was CT, then we will repeat the CT, or we can do PET-CT scan. I think the patient is not responding and there is a clinical progression. If it is confirmed on imaging, then we will either go for a supportive care depending on the childhood staging and the fitness status of the patient, or change the treatment.
So suppose we did a PET scan. I know there is some mix up with the slides, but suppose we did a PET scan and the patient had response on the PET scan. So how will you still manage this case?
Sir, then either it could be a case of hepatitis due to immunotherapy, because you have mentioned raised OTPT. We need to evaluate for that also. Either whether the OTPTs are declining after the stoppage of the immunotherapy and other immunotherapy side effects. A second thing, it can be due to the cirrhosis component itself, that ascites is forming. Then we can take care of the ascites, and the CLD management can be done and treatment can be continued. Steroids can be used if warranted, depending on the grade of the OTPT elevation and the hepatitis.
Okay, so when you choose in your clinic, a new HCC gets diagnosed, does your treatment, how do you choose the treatments? Does it depend on what is the cause behind HCC? So if it is
Uh,
Hep C, it is Hep B, it is NASH, it is alcohol. So these are the
uh,
four most common causes. So does your treatment for four of these causes is
Sir,
same or different?
so the guidelines do not mention that we have to distinguish on the basis of etiology, but there are some studies which says that NASH patients respond, I think, better to the immunotherapies as compared to the viral etiologies. But the data is not very clear, and the guidelines still say that irrespective of the etiology, you can choose atezo plus bev if the patient has financial viability and other child
I think
PK scoring.
responds better to TKIs, isn't it?
Dr.
Uh,
Priyanshu? Hello? Am I
Responds
audible,
better to lenvatinib or other TKIs.
So if it is viral, probably the atezo-bev combination is better, and if it is NASH, then probably TKIs are better.
Yes, that's what I'm saying. TKIs,
TKIs,
lenvatinib and all
they
that,
have
NASH.
some theoretical advantage in NASH, but again,
But again,
you know,
these are not prospective clinical
these are not
trials. These
prospect.
are,
This is what I was
yes,
trying to come to say, that this is not
This is the
prospectively validated.
subgroup analysis and post hoc analysis of trials.
Correct. So I think on day one, still, if anybody is diagnosed with the metastatic HCC, which is unresectable, the guideline wise, the treatment of choice, if the patient can afford and performance status allows, would be atezo plus bev. So this is the exploratory subgroups, of updated IM Brave 150, where HB viral etiology basically they have more advantage, and patients with non-viral histology did not have much advantage in OS and PFS subgroups. So depending on the etiology, whether it is HBV, HCV, or non-viral, again we have to see the same thing. So this was the the baseline characteristics that were included in the trial. We will not go into the details of this. So this is the survival of trial-like and non-trial-like patients with immunotherapy and advanced hepatocellular carcinoma in real world. A collaborative multi-center Indian study, IMHEP, and this study shows that in patients cohorts, one which had atezo plus bev, nivo, and pembro. Patient, they had entire cohort was median 12-month OS was 33.4%, and patients in cohort 1 had a significantly improved OS compared with patients in cohort 2. So patients in advanced HCC in the real world trial like survivals in consonance with trial data, where patients with features excluding them from the trials, such as main portal vein thrombosis, poor ECOG performance status, and child POC B status, have markedly inferior survivals despite good tolerance to immunotherapy. So, what is the effectiveness and safety of atezo-bev in patients with unresectable hepatocellular carcinoma? So, this is a systematic review and meta-analysis where it was shown that although PFS with atezo plus bev was better in CTPA than in CTPB, objective response rates and incidence of adverse events were comparable. And atezo-bev actually yielded better overall response rates in the first line setting than in the second line setting among these 9 studies. So this is what we were discussing, that on day one, if a patient is able to tolerate and afford, then in first line atezo plus bev would be the treatment of choice. So this is the clinical spectrum of intermediate stage HCC. What to do in intermediate stage HCC is a debate that will happen with most of our patients. Then we have to discuss it in a multidisciplinary tumor board, and depending on the inputs from the the intervention radiologist, the surgeons, and the medical oncologist, we arrive at a particular diagnosis. So coming on briefly to case 2, where a 38-year-old gentleman, abdominal pain, HBsAg positive, diagnosed with liver lesion, evaluated, again CLD, raised AFP, and CPS A6 PS1, no varices seen. So patient was diagnosed as BCLC-C and no extrahepatic spread, portal vein thrombosis. So any locoregional therapy for this, Dr. Mukesh?
I think, sir, TARE can have a role in this. We need to look at the city. Where exactly is the
So where exactly is the lesion, sir? It is including main portal vein?
No, it is not in the main portal vein. So it is contiguous with the portal vein thrombosis. Primary disease present in left lobe of liver with contiguous portal vein
Okay,
thrombosis.
okay.
So
So
it is
we
not
can
in the.
go for tear plus SBRT in this case also, or otherwise we can go for a neoadjuvant sort of immunotherapy in this
So,
case.
Dr. Priyanshu, at your setup in your practice, what loco-regional therapy do you end up using for most of your patients?
So I have TACE available, and there is data of using periprocedural lenvatinib with that. And in this patient, I think so there are multiple lesions in the right lobe also. Can you go back?
Yes.
So I don't think so this would be a suitable candidate for. Can you go back? Yeah, multiple nodular lesion in the likely metastatic deposit. So I think so this is a multicentric
This is a
disease.
multicentric HCC imaging wise. So I think the
Yeah.
report doesn't collaborate with this. But anyhow,
Yeah.
so the message is that if a loco-regional therapy can be added to the systemic therapy, this is based on the Emerald-1, a phase 3 randomized placebo-controlled study of transarterial chemoembolization when it was combined with Durva, with or without bevacizumab, in patients with unresectable hepatocellular carcinoma who were eligible for embolization. So if we see here, PFS with Durva Bev TACE versus placebo plus TACE, the median PFS was actually longer when a TACE was added to the placebo therapy, to the systemic therapy, sorry, and the median PFS was 15 months versus 8.2 months, and the hazard ratio was 0.77. So I am not going into the details of this because some slides are missing and some are above and down. So I think the summary is that these are exciting times in HCC. First line, it is atezo plus bev if not are not having any contraindications. Durva Tremi is a recently approved indication, but again, it is not available. Tremi, I think. If no IO, then lenvatinib. There is a new evidence of this ASCO of EP plus Nivo in this space. And if a patient progresses to second line, and if no IO in the first line is given, then obviously the patient has to be offered atezo-bev. But if a patient has already received this, then we have to rely on either immunotherapy alone or the oral TKIs. So, Dr. Priyanshu, what is your take on the recent evidence of Nivo plus EP in the first line HCC?
Nivo-IP, sir, I think so. The data, OS data, is it mature? I think so. It is. As
No,
of now, it is.
It
Yeah,
is not,
it is
but
immature.
correct. But it had shown the overall response rates were higher when compared to atezo plus bev in that trial.
Yeah.
Dr. Mukesh?
So we have presently shifted one patient from atezo-bev to Nivo-IP because of poor tolerance to bevacizumab because of the recurrent bleed and upper GI varices. So
Okay.
the response assessment is due, but we have now shifted.
So the patient was not able to tolerate bevacizumab, correct?
Yeah.
Okay. So I think these are the most common therapies available. The only new entrant is the Nivo plus IP in this space, and rest all things we have mostly covered. So I thank you. I thank all the panelists for the active discussion. Thank you. So moving on to the next session in this virtual meeting. The next session is on GU cancers, and for GU cancers, the session is sponsored by Amneal, and the topic is management strategies in CSPC and CRPC with real-world evidence in relugolix. And we have with us Dr. Ketan Dang, He is a consultant medical oncologist at Fortis Hospital, Mohali. And I welcome Dr. Ketan to give and deliver his talk on relugolix and CSPC CRPC. Nishant, is Dr. Ketan there?
Sir, Dr. Ketan Ramsey is here.
Pardon?
Good evening and welcome everybody.
Good evening, Dr.
Thank you,
Ketan.
Doctor. Good evening, Dr. Chitresh. Thank you for this valuable opportunity. So without wasting further time, I'll start with the presentation. Can I have my slides, please? Yeah, sharing.
Yes, sir. Yes, sir.
Just a second. Are the slides visible?
Sir, visible.
Yeah. So today we'll be discussing the evolution of prostate cancer treatment, past, present, and future. In fact, the focus is mainly on a molecule called relugolix, that is the newer GnRH antagonist that is administered orally. And we'll be discussing the major advancements and the pivotal trial that compared this agent with the GnRH agonist and its implications on this disease. So, starting with the historical perspective, we know that 50 years ago, typically men were diagnosed with this disease in the late 70s, and that had already metastasized to the bone and the soft tissues, and patients usually used to die within a period of 2 years. Then it all started with Charles Huggins, who in the 1940s found that metastatic prostate cancer responds to androgen deprivation. And this was a great discovery that ushered in the era of hormone therapies. And then medical castration became the first effective systemic therapy for any cancer. And even to this day, we all know in various forms, whether it is surgical, orchidectomy, or medical, agonists or antagonists, oral or parenteral, we are using them, and they are still the one of the mainstays of our therapy, despite so many advancements. So this slide beautifully shows in the lower half the various developments starting from 1936 to the present day, starting from Ethelyn Alexander, who described acid phosphatase activity in CA prostate, then Huggins, then the Weckert study that reported the benefits of hormone therapy. Thereafter, in the 1980s, the LHRH agonists came in, and FDA had approved leuprolide first of all. And thereafter, anti-androgens were approved. And then there was a discovery of enzalutamide and abiraterone followed by enzalutamide. And then the various advancements that we often discuss in our meetings to date. And the latest being apalutamide, darolutamide, and the management of BRCA-mutated cancers and MSI high and tumor mutated burden high TMB cancers, where we have been using immunotherapies and the use of lutetium. So again, this is the historical perspective which I've already discussed, and we'll move on to the main topic. A word about these main three agents. Abiraterone. The realization that advanced prostate cancer relies on testosterone led to the use of Abira, which has been very effective in significantly reducing the tumor size. But the use of abiraterone is as such depending on the clinical spectrum of prostate cancer which you're treating. Then enzalutamide, how does this work? So this works by blocking the androgen receptor and function specifically by binding to its ligand binding domain, thereby preventing the binding of androgen to the AR, the receptor, and thereafter it blocks the subsequent events happening on the DNA in the nucleus. Then relugolix, it is an oral GnRH antagonist. We have an parenteral antagonist, that is degarelix, which is given monthly subcutaneous, This is the oral one, and it is a new approach in managing the advanced prostate cancer by rapidly decreasing testosterone levels without the initial surge that we see with LHRH agonists. We all know that once we use LHRH agonists, especially in patients where there are a lot of spine metastasis or there are a lot of liver metastasis, and we know our flare of initial testosterone high can happens with LHRH agonism, and most of the clinicians usually give anti-androgens like bicalutamide for initial first 2 to 4 weeks of anti-androgen therapy to cover that flare. And we know that that flare is obviously not seen with the antagonist. And also, we also know that the risk of cardiovascular events is much lower with the antagonist compared to the agonist. And now here we have relugolix that is in the oral form that is even more effective. So the management of prostate cancer in the various states, whether it is the CSPC, metastatic CSPC, or the non-metastatic CSPC and the CRPC. So it's a topic in itself. With each situation, there is a long discussion. So we'll be focusing on this newer ADT, that is the HERO trial that led to the approval of relugolix. So as they said, injectable LHR agonists, for example, leprolide, goserelin, triptorelin, they are the standard agents for achieving androgen deprivation for CA prostate. Although they cause initial surge in the testosterone level because they are the agonists, and this can also lead to a delay in the therapeutic effect. So this HERO trial was a phase 3 multinational trial that compared relugolix oral agent with injectable agonist leprolide in patients of advanced CA prostate. This includes patients in all these three spectrums that I already stated, and they were randomized in a 2:1 ratio to receive either relugolix, which is given in a dose of 360 milligram orally on day 1 with or without regard to food, and thereafter 120 mg orally once daily, or the other arm was leprolide. For 48 weeks, they were assessed. Total of 622 patients were on this drug, and 308 received leprolide. So the primary endpoint was sustained castration, which we define as a testosterone level of less than 50, and that was from the period of day 29 to 48 weeks. And we know profound castration we defined as a level less than 20. The secondary endpoints, there were several, including non-inferiority. When the non-inferiority of Regulix was established, then assessing superiority was the next step, and the margin was 20 minus 10%. Then the other secondary endpoint was a probability of castrate level at day 4, day 15, probability of PSA response, profound testosterone suppression, that is level less than 20 nanograms per deciliter at day 15, and the mean FSH level. And they studied how FSH level was controlled with leprolide versus relugolix at 6 months. So here we can see these wonderful results. Here we can see on the bar diagram on the left side that the 96.7% of men on relugolix versus 88.8% on leprolide, they had maintained castration level for 48 weeks. So that is a difference of kind of 8 to 9%. On the middle, we can see the graph of the mean testosterone level among all the patients, and we can see that the mean testosterone levels over time, including recovery 30 days after discontinuation of trial, and at the end of week 48, the percent of patients with castrate levels of testosterone day 4 was 56% with relugolix, and nil, that is important, so with leprolide. So we can see how rapidly acting relugolix is. At day 4, we can see the tremendous difference. And thereafter, in the third half of the slide on the right side, we can see the mean testosterone level in subgroups followed for the recovery. Once this therapy is on hold, then how does the testosterone recover? and that recovery is also much faster with relugolix. In the subgroup of 184 patients followed for recovery, the percent of patients with testosterone recovery to at least 280 mg level at 90 days after discontinuation of trial treatment was 54% much higher in the relugolix group and 3% in the leprolide group. So this recovery leads to the improvement of the symptoms of the patient and is quite important. Then regarding the adverse effects, the cumulative major cardiovascular events, here we can see that relugolix was much safer compared to leprolide. After 48 weeks of treatment, the incidence of major adverse cardiovascular events was 2.9% in the relugolix group and 6.2% in the leprolide group. KM estimates of the incidence rate were consistent with a 54% lower rates, that is a hazard ratio of 0.46 in the study group than in the leprolide group. So all these things conclude that relugolix achieved rapid, sustained suppression of testosterone levels that was superior to that with leprolide with a 54% lower risk of major adverse cardiovascular events. So this is a slide from the NCCN showing the treatment and monitoring of progressive M0 CSPC after maximal pelvic therapy. This is itself is a vast topic, the workup for the metastasis. We all know how we decide on therapy in the metastatic setting. High volume disease, we all know we define as either visceral metastasis or 4 or more bone metastasis with at least one outside the vertebral column and the pelvis, and how we select our patients for docetaxel or docetaxel plus oral agent versus abiraterone and continuing the ADT. So this graph on the left side shows a beautiful pattern of prostate cancer progression to CRPC, the timeline of the various treatments, which we can see in the castration sensitive phase and as well as in the castration resistant phase. On the right side, we can see the median survival after treatment with second generation anti-androgens. They are all kind of comparable. A word about the PSA doubling time and its importance in non-metastatic CRPC. So this is quite important because PSA DT, some say less than or more than 10 months or 12 months, is of vital importance because survival of rapid prostate-specific antigen doubling time in patients is associated with the risk of metastasis and survival. Most patients who have a PSA DT of more than or less than 12 months, so the lesser the doubling time, the higher the risk of metastasis and death in short. So an analysis of 2800 patients was done and it was found that related to the patients who had a PSA doubling time of more than 1 year to less than 2 months and 2 to 4, 4 to 6, 6 to 8 and all this, those who had a shorter doubling time had a significantly higher metastasis and mortality risk and higher healthcare costs. And this can help select patients for novel therapy. And this slide is a busy slide that shows the clinical factors to select treatment for CRPC. So it's a complex topic in itself. Our focus here is on the neuroantagonist. So to conclude, we have a valuable newer addition to our ADT armamentarium, 3 agonists, and a second, an oral antagonist is now available, which is quite rapidly acting and is quite effective and with lesser side effects. That's all. Thank you.
Thank you, Dr. Ketan, for that wonderful talk. I just want to have your input on how is your experience with the usage of relugolix?
Frankly, I have just now prescribed it. I don't have a first-hand experience of it. But cost-wise, it is not a problem. I think the cost is comparable of oral versus parenteral dosing. But frankly, I have just prescribed it and I'm yet to see my own, to experience it, my own practice. What about you, Chitresh? How has your experience been?
And morning. So I have initiated 1 or 2 patients, but it is too early to comment.
Yeah.
So tomorrow morning, a new patient requires ADT. How do you choose between oral and the conventional form?
So basically, the basically depends on the patient profile, not only their affordability. The most important is there any risk of androgen flare, or is the patient susceptible to any cord impression or a visceral uh, metastasis that can lead to decompensation of liver function. So there, that leads to that. I think is the dividing line between the antagonist and the agonist. If there is an urgency, then I can't wait for 2 to 4 weeks of anti-androgen therapy first, followed by this. So definitely antagonist. And in antagonist, I think there is a huge cost difference between the oral agent and the parenteral, that is Tegarelix. So that is these are the few factors that are quite important. And if there is a cardiovascular disease, then obviously our choice will be an antagonist.
Thank you, Dr. Ketan, for your valuable inputs and a wonderful talk. So now moving on to the next session, that is current treatment landscapes in first-line urothelial cancer. And the talk would be delivered by Dr. Deepak Singla. He is the head of medical oncology at Indus Group of Hospitals at Derabasi, Mohali, and Ambala. And I welcome Dr. Deepak. And
Yes. Good evening. Good evening, Dr. Chitresh. Am I audible?
yes, sir, you are audible.
Thank you, Dr. Chitresh, for giving me this opportunity. And in the next 10-15 minutes, we will be discussing about the matters. What is the first line choice in the? Can someone share the slide, please? Vishal,
Yes,
from
sir.
Horizon, please. Nishant, please share the slides, please. So in the next 10-15 minutes, we will be discussing what is the first line choice of metastatic urothelial cancer. And dear friends, we have seen in the last 10 years unprecedented improvement in the overall survival of a metastatic urothelial cancer, especially the C urinary bladder. We live in a time where the metastatic urinary bladder cancer patients live up to 2 years, 3 years with the with the invent of new ICIs, and is the one of the tumor which is having the one of the second or third tumor which is having the highest genetic alteration. More than 93% of the patients are having a genetic alteration, and out of them a quite significant number are the targetable. So my broad scheme of discussion will be chemotherapy first line, immune check inhibitor post chemotherapy maintenance, and if the patient is not eligible for the platinum overall, so which ICI we can use that. Next slide, please. So chemotherapy, as we know, platinum is the gold standard, gemcisplatin, and equally efficacious, less toxic than the standard MVAC protocol. And even on the toxicity wise also, gemcitabine and platinum has a edge over the MVAC. And even on the dose dense MVAC also. So carboplatin can be replaced with the cisplatin in eligible patients. And addition of the third gun, taxane, I have never used it, but we don't know the benefits. Next slide, please. So we know from the data from the Javelin Bladder 100 trial, immune check inhibitor post chemotherapy, evolumab maintenance therapy, in which the is was a phase 3 trial, Javelin Bladder 100 trial, in which the number of patients 700 were enrolled. Overall survival was 21.4 versus 14.3 months, with a hazard ratio of 0.69 with a 95% of a confidence interval with a p-value more significant 0.001, and toxicity was comparable. And the PDL, so this is a PDL agnostic, and post-cisplatin based chemotherapy, it is a category 1 recommendation. Next slide, please. Dishan. So, immune check inhibitor first line when and how, if the platinum eligibility, patient selection, and the ICI evidence and action at pembro. Next slide, please. So, as we know that when the patient came to us and the 50% of the patient are cisplatinum eligible, and while the remaining 50% are ineligible. So in our clinical practice, I mean, maybe these figures are not true. I mean, we maybe cisplatinum eligible is more than 50% we see majority of the time. So if the patient is cisplatinum, we will follow the Javelin trial. GEMS is followed by a Evolue maintenance, or we can go ahead with a dose dense MVAC followed by Evolue maintenance. However, majority of our patients are cisplatinum eligible. We know the cisplatinum eligible criteria. The GFR should be more than 60 ml per hour, and neurosense, the hearing load should be less than 2. Less than, and peripheral neuropathy should be grade less than 2. So all these patients are eligible for the cisplatinum. But out of, if the patient is not eligible for the cisplatin, we can either use atezolizumab or pembrolizumab if the patient is PDL1 positive patients. Okay, and if or we can use carboplatin based regimen if the patient is PDL1 negative, followed by a evolizumab maintenance. Next slide, please. So we have so one interesting facts are we have seen that this is one of the rare tumor in which the giving ICI before the chemotherapy can be detrimental to the patients. We have seen that there is a decreased survival patient who in the ICI group of patient in which the first line monotherapy was used compared to those receiving cisplatin. Choose chemotherapy even for the PDL high patient, even for the PDL is high and platinum eligible patient. Do we need PDL checking for at all? Yes, we need to check the PDL status for the majority of our patients, especially for the atezolizumab. Chemotherapy plus ICI, is more effective than the ICI monotherapy. Next slide, please. So, I mean, there are two frontline agents which are used in the patients in the monotherapy as a monotherapy based upon the Invigor 210 and 13 phase 3 130 and pembrolizumab Keynote 052 and 361. Next slide, please. So, Invigor cohort 1, it was a single arm phase 2 study of atezolizumab in metastatic urothelial cancer. Cohort 1 inclusion criteria was locally advanced metastatic transition cell carcinoma of the urothelium, fresh frozen tissue specimen for the PDL1 analysis via Ventana ISC, no prior treatment of metastatic urothelial cancer, more than 12 months since the perioperative chemotherapy, ECOG performance status 0 to 2, and patient must be cisplatinum eligibility. And the primary endpoint was overall response rate, and the secondary endpoint was progression-free survival and the duration of response. And the atezolizumab was continued till the progression of the disease or non-tolerable toxicity. The next slide, please. So looking at the overall response rate, not that great. Overall response rate was approximately it was only 24% with a follow-up of 29.3 months, and duration of the response median has not reached, and patient with ongoing response are only 19 out of 28, and median duration of response is in patient with CR. It was also not reached, and median duration of CR yet to become, and ongoing CRS data cutoff was only 8% patients were having a CR, and the median overall survival has increased from 14.8 months to 16.3 3 months. Next slide, please. So the duration of the duration of response in the responder, the median duration of response of follow-up, it was 29 months, and median duration of follow-up for the patient in CR, it was 31.7. Overall response rate was 24%, and CR was 8%, and median duration of response not reached, and the median duration of CR also not reached, and ongoing CR at data cutoff was 8% only. And we can see that in the patient who has received the CR at the end of the 2 years, majority of the patients were alive at the end of the 24 months. Next slide, please. So cohort 1 efficacy in elderly patients, InVigo 210 cohort 1. So it is efficacious in elderly patient more than 75 years, are irrespective of the irrespective of the PDL1 groups, and and more than 75 years, generally consistent with the overall population in this long-term analysis. There was no age-related efficacy difference between the PDL1 age group. Next slide, please. So now the combination InVigor phase 3 study of atezolizumab plus minus platinum-based chemotherapy for first-line metastatic urothelial cancer. It was a 3-arm study. Again, the eligibility criteria remains same: local or metastatic urothelial cancer, no prior systemic therapy in the metastatic setting, eligible for the platinum-based chemotherapy, and tissue sample available for the PDL1 testing, Ventana SP142. Arm A was atezolizumab and gem plus platinum. Arm B was monotherapy atezolizumab, and third arm was platinum plus gemcitabine plus placebo. It was continued to until the PD or unacceptable adverse events. Primary endpoint was PFS and OS, A versus arm A versus C, and secondary endpoint was overall response rate and PFS and OS versus monotherapy versus versus C arm, which was chemotherapy plus placebo arm. Next slide, please. So we can clearly see that if we see the difference between arm A and versus arm C, so chemotherapy in the arm C, which is the chemotherapy arm, there is a median progression-free survival of 8.2 months as comparatively to the arm A, which is atezolizumab and platinum plus gemcitabine. It was median PFS was 6.3 months. So adding chemotherapy upfront, adding ICI with the chemotherapy upfront is not beneficiary as comparatively to the chemotherapy upfront. Next slide, please. So if you see that interim overall survival analysis also, median overall survival was in the arm C, which is again chemotherapy arm plus placebo. It was 16 months, and as comparatively to the arm A, it was 13.4 months overall survival. Next slide, please. So if we see interim overall survival by PDL1 status, arm A versus arm B, and we can see that in the arm C, the overall survival was 15.4 months, 15.4 months as comparatively to the 13.1 month in the combination arm, which is if we compare arm B versus arm C, monotherapy versus only chemotherapy plus placebo, again arm C has an edge 59.9 months versus 13.3. So even improved overall survival with in the atezolizumab monotherapy was associated with only with the PDL1 IC2 and IC2/3 status. Next slide, please. So first line patients who are not eligible for the cisplatin containing chemotherapy, whose tumor expressed PD-L1 as measured by the PD-L1 TPS 5%, Ventana SP 142. Patients who are not eligible for the platinum containing chemotherapy regardless of the PD-L1 expression. Next slide, please. So coming to the second drug, pembrolizumab, first line pembro in cisplatin ineligible patients with locally advanced and unresectable or metastatic urothelial cancer, Keynote 052, a multi-centering single-arm phase 2 study. Next slide, please. It was so the first line pembrolizumab in patient with locally advanced unresectable metastatic disease, urothelial cancer. It was a single arm phase 2 study in which we can see that uh, uh, majority the patient who had a complete response, they were alive. They were alive at the end of the 2 years. Next slide, please. So so overall response rate, responder were more than 52% at the end of 24 months, and overall survival was at the end of 2 years, it was 31.2%. Next slide, please. So first line combination trial, it was IMvigor 130 versus Keynote 361. And we should know that the monotherapy atezolizumab and pembro was halted by the FDA when they found that the patient with the PD-L1 low group had a decreased survival. Next slide, please. So pembrolizumab, only patient who were not eligible for platinum containing chemotherapy, they in their pembrolizumab can be given. Next slide, please. Go to the previous one, please. Nishant, yes. Next slide, please. Yeah. Next, Nishant. So first line immune check inhibitor pembrolizumab, atezolizumab. It was a phase 2 Keynote 052, phase 2 IMvigor 210 cohort 1. So median OS was seen in the pembrolizumab arm was 11.3 months, but overall response rate was also 28.9%. as compared to 23% in atezolizumab arm with a median overall survival of 15.9 months, and median PFS was 2 months versus 2.7 months, and grade 3, grade 4 treatment adverse event was higher with the pembrolizumab versus 16% in the atezolizumab. Next slide, please. So management algorithm, metastatic urothelial cancer, patient could be cisplatin eligible, carboplatin eligible, or platinum unfit. Patient with cisplatin eligible, GemCis is the standard of care, carboplatin eligible, gem carbo, platinum unfit, ICI. If the patient is platinum resistant, we have to switch to the patient to the ICI. If the patient is ICI resistant, we can either use for taxanes or vinflunin, or novel therapeutic strategies like enfortumab vedotin, which we know that it's a new ADC, which is a new ADC, nectin inhibitor, or FGFR inhibitor, and sacituzumab govitecan. But the thing is, next slide, please. Next slide. So PD-L1 and PD-L1 inhibitor have been improved for first-line metastatic urothelial cancer. Is in Europe, it is PD-L1 positive cisplatin eligible, GemCis, followed by followed by maintenance, and first-line PD-L1 positive but cisplatin ineligible, GemCarbo, followed by pembrolizumab. While in USA, it is GemCis remain the same, or in the cisplatinum ineligible patients, GemCarbo followed by pembro or atezolizumab. First line platinum ineligible, pembro and atezolizumab regardless of the tumor. First line maintenance is avelumab as per based upon the Javelin 100 data. Next slide, please. To conclude my talk, that this in the bladder cancer, in metastatic urothelial cancer, there are quite good number of genetic alterations. So we always look for maximize genetic alteration at the baseline, getting NGS done, and followed by looking for the eligibility of the patient, and then followed by chemotherapy or upfront ICI. Thank you so much, Dr. Chitresh, for
Thank you, Dr. Deepak. We'd like to have your input in your day-to-day practice. What is your preferred first line you offer to your patients? And do you use Gemcitabine alone, or do you add nivolumab to Gemcitabine? How do you practice in your first line patients?
I generally don't add nivolumab to Gemcitabine, and majority of our patients are not cisplatin eligible. Okay, I mean, if the patient is, I usually go for a maintenance. I usually go for a maintenance ICI.
Okay.
Yeah, I use this nivolumab only in the adjuvant setting, post cystectomy patient who are nodal positive. Yeah.
Thank you, Dr. Deepak, for your talk and inputs. So moving on to the next talk. This talk would be given by Dr. Priyanshu Chaudhary, and I welcome Dr. Priyanshu. The topic is PARP inhibitors in ovarian cancer in present scenario. To Dr. Priyanshu, please.
Thank you, sir. I request the tech team to please present my slides. Next. So topic today is PARP inhibitors in ovarian cancer. So if we see the treatment overview of advanced ovarian cancer, the first is usually neoadjuvant platinum-based chemotherapy for select patient, followed by surgical staging and debulking, and adjuvant platinum-based chemotherapy, followed by frontline maintenance therapy or observation. And most of the patients usually relapse and then again are given chemotherapy and then maintenance of recurrence. So maintenance therapy can be offered in frontline or the recurrent setting. Next. First, we'll discuss the first line maintenance with PARP inhibitors in advanced ovarian cancer. Next slide. So if we look at this circle, if we look at the pie diagram here, almost a quarter of the patients are usually BRCA mutated and 75% are BRCA wild type. But again, if we look at the HRD portion, almost half of the patients have HRD positivity. So this is the approval data. If we look at olaparib with or without bevacizumab, olaparib alone, 2018 FDA approval in BRCA mutated, following a complete or partial response to platinum-based chemotherapy in frontline maintenance setting, with bevacizumab in HRD type, HRD positive, BRCA wild type, while in HRD negative, not yet approved. Niraparib again approved in all the three settings: BRCA mutated, BRCA wild type HRD positivity, as well as BRCA wild type HRD negative. Similarly with rucaparib, which is guideline endorsed yet but not FDA approved. Next. So these are the phase 3 clinical trials of frontline maintenance of PARP inhibitors. So they have changed the treatment paradigm of advanced ovarian cancer. So very beautiful this chart we have. So olaparib SOLO-1, BRCA mutated, stage 3-4, high-grade serous or endometrioid response following platinum-based chemotherapy. In PFS and BRCA mutated, hazard ratio is 0.3. Not effective in HRD positive, BRCA wild type or BRCA wild type HRD negative. Niraparib PRIMA study, stage 3-4, high-grade serous or endometrioid response following platinum-based chemotherapy. Again, all the three indications, all the three subtypes, it had shown a PFS benefit. The hazard ratio being best in BRCA mutated, 0.40, BRCA wild type HRD positive, 0.50, BRCA wild type HRD negative, 0.68. Similarly, PAOLA-1, olaparib plus bev, stage 3-4 high-grade serous or endometrioid or germline BRCA mutated non-mucinous epithelial ovarian cancer, response following platinum and taxane chemotherapy plus Bev. So again, benefit is there in BRCA mutated 0.31 hazard ratio of PFS, as well as BRCA wild type HRD positivity 0.43 is the hazard ratio, but not in HRD negative tumors. Rucaparib Atheno monotrial, again, similar population, hazard ratio of 0.40 in BRCA mutated, BRCA wild HRD positivity 0.58 and 0.65 in BRCA wild type HRD negative. Next. So in first line setting, HRD genomics instability clearly predicts for magnitude of PARP inhibitors. So if we look at the Paula-1 HRD positive tumors, again, the median PFS significantly prolonged, the 37.2 versus 17.7. So the incremental benefit is 19.5 months, while in BRCA wild type HRD positivity, the benefit is 11.5, while in HRD negative, it is only 0.9. Similarly, in the PRIMA study, the benefit is 11.5 in HRD positive HRD positive, while in BRCA wild type HRD positivity is 11.4 and only 2.7 in HRD negative tumors. Next. This is the SOLO-1 trial, olaparib versus placebo as first line maintenance in ovarian cancer in the German. Am I audible?
Dr. Priyanshu, your voice was not audible.
Am I audible now?
Yes, you are.
Yeah. So again, SOLO-1 patient with newly diagnosed FIGO stage 3-4 high-grade serous or endometrioid ovarian with germline or somatic BRCA, ECOG PS0 to 1, CRS and CR or PR to platinum-based chemotherapy, randomized 2:1 to olaparib, standard dose 300 mg BD versus placebo up to 2 years or continued beyond 2 years if there was a PR. Primary endpoint PFS, secondary PFS by BICR, PFS2 OS, time to subsequent therapy or death, and health-related quality of life. Next. So the PFS, investigator assessed PFS, again, significantly prolonged, median PFS of whooping 56 months versus 13.8. The difference is 42.2 months, hazard ratio 0.33. And if you look at the 5-year, PFS is 48%, which is very significant. Next slide. So at the longer 7-year follow-up, the overall survival was not reached. The median OS was not reached versus 75.2, but it was significantly better, hazard ratio of 0.55, p-value significant, and at the end of 7 years, 67% of the patients were alive. Next. So time from random assignment to first subsequent therapy or death were also significantly prolonged. Median TFST was 64 months versus 15.1 months. Hazard ratio of 0.37. Next. And if we look at the most frequent treatment-related adverse events were, there were no new adverse events. It were across the, it were similar to what were expected. GI, mainly GI side effects and hematological. Next slide. Then there's the Paula-1 trial. It was a randomized phase 3 placebo-controlled trial for newly diagnosed FIGO stage 3 to 4 high-grade serous or endometrioid ovarian, fallopian tube or primary peritoneal cancers. Patient with PR or CR after upfront or interval surgery and standard platinum or taxane-based chemotherapy, and with 3 or more cycles of Bev were randomized to 2:1 to olaparib, 300 mg BD for 2 years, plus Bev 15 mg per kg every 3 weeks for 15 months versus placebo plus Bev for 15 months. So the primary endpoint was investigator assessed PFS. Key secondary endpoint were PFS2, OS. Next slide. So these are final results. The median PFS significantly prolonged to 46.8 months versus 17.6 months. This is in the HRD positive subgroup we're talking. And the 5-year PFS rates were 46.1% versus 19.2. So olaparib plus bevacizumab significantly prolonged the PFS in HRD positive subgroup compared to placebo plus bevacizumab. Next slide. So again, the final result from the OS in the HRD positive subgroup again, significantly prolonged, 75.2 versus 57.3 months, and the 5-year OS rate was also higher, 65.5 versus 48.4, hazard ratio of 0.62, and 17.3% and 50.8% of the patient in OLA plus BEV and placebo plus BEV arm respectively received PARP inhibitors during any subsequent treatment. Next slide. So again, these are the final results from PAOLA 1 OS by HRD status. Again, if we can see, it is significantly prolonged, in BRCA mutated as well as HRD positive tumors, excluding BRCA mutated. While in HRD negative, the overall survival was not statistically significant. Next. Then is the Athena mono study, again a phase 3 study with similar population, post CRS, 4 to 8 cycles of first line chemotherapy, and PS 0 to 1, randomized into 4 arms. The current analysis is between arm B versus arm D. So arm B is rucaparib 600 mg BD plus placebo every 4 weekly versus placebo plus placebo. Primary endpoint PFS, secondary OS, ORR, DOR, and PFS and safety. Next slide. So these are the baseline characteristics. They were well matched. Next slide. So next. Yeah. So again, in the intention to treat population, that was the PFS in intention to treat population, that was the primary endpoint. Rucaparib maintenance significantly prolonged investigator-assessed PFS versus placebo in intention to treat population, and similar results observed with BICR-assessed PFS. So rucaparib, the median PFS in the rucaparib arm was 20.2 versus 9.2 in the placebo arm, and the 2-year PFS was again 45.1 versus 25.4 months. Next slide. In the in the HRD population, the investigator assessed PFS was again significantly prolonged, 28.7 versus 11.3 months, hazard ratio 0.47. Next slide. So investigator assessed PFS in HRD positive and negative populations, again rucaparib in HRD positive not reached versus 14.7, hazard ratio 0.40. In the HRD negative population, it was 12.1 versus 9.1, hazard ratio 0.65, and with BRCA wild type but HRD positivity, that is loss of heterozygosity, then hazard ratio 0.58 and median 20.3 versus 9.2. So all the 3 subgroups are benefiting. The magnitude of benefit is highest with BRCA with HRD positivity and BRCA mutated tumors. Next slide. So again, this is the forest plot. Almost all the subgroups are benefiting. Next. Next. So coming to the most common treatment-related adverse events were mainly GI, nausea, asthenia, fatigue, and hematological anemia, neutropenia, transaminitis, diarrhea, vomiting, dysgeusia, arthralgia, headache, constipation, decreased appetite, and pruritus. But the grade 3 or more side effects with rucaparib were very less. And transaminitis, neutropenia, and anemia, they were significant compared to placebo. Next. Then coming to the PRIMA study, the first line niraparib versus placebo in ovarian cancer at high risk of recurrence after first line platinum. Similar population, randomized to niraparib 300 mg OD into 28-day cycles versus placebo up to 3 years or until progression. The dosing was amended in between to 200 mg OD if less than 77 kg body weights or platelets less than 1.5 lakh or both. Primary endpoint PFS, secondary endpoint OS, PFS2, quality of life, PRO, and safety. Next. Baseline characteristic well matched, but they this trial included patients with a poor prognosis. Residual disease after primary debulking were around 85% and stage 4 disease were 35%. And PR to first line clinical platinum chemotherapy 31%. Next. So PFS in HRD versus overall population, if we look at the HRD positive population, again the median PFS 21.9 versus 10.4, hazard ratio of 0.43, while in overall patient population, again if we see median PFS 13.8 versus 8.2, hazard ratio 0.62. Next. So niraparib provided clinical benefit in HRD, BRCA mutated and BRCA wild type and HR proficient subgroups. So we look at the three subgroups here. HRD, BRCA mutated, hazard ratio 0.40, significant benefit with PFS. BRCA wild type but HRD positivity, again significant benefit with PFS, hazard ratio 0.50. While in HRD negative and BRCA wild type, hazard ratio is 0.68. So all the subgroups are benefiting. Next. So the most common adverse events were anemia, thrombocytopenia, decreased platelet count, from neutropenia, but they were manageable and consistent with PARP inhibitors class. Next slide. So the guideline recommendation for PARP inhibitors as frontline maintenance, if newly diagnosed platinum-based chemotherapy, we achieve a CR or PR with BRCA wild 1 or 2 mutant, we can give Nira, Ola, or Rucaparib. In HRD positive, Olaparib plus bevacizumab or Rucaparib. In HRD negative, Niraparib or Rucaparib. Next. Now coming to PARP inhibitors for relapsed ovarian cancer. Next. So maintenance following response to second-line platinum-based chemotherapy should only be offered to PARP inhibitors naive patient as per the ASCO guidelines. So Olaparib is approved in all the three BRCA mutated, BRCA wild type HRD positive tumors as well as BRCA wild type HRD negative. While Niraparib is approved only for germline BRCA mutated as well as Rucaparib for only BRCA mutated tumors. Next. So these are the studies for second line. If we look at the study 9, Olaparib versus placebo, median PFS prolonged in the overall population as well as BRCA mutated as well as the wild type. All the three groups similar with the OS. Solo 2, Olaparib versus placebo in only BRCA mutated tumors, PFS 19.1 versus 5.5, hazard ratio 0.3, OS 51 versus 38.8, hazard ratio 0.74. Nova, Niraparib versus placebo, again significantly prolonged PFS in all the subgroups as well as but the OS was better only in germline BRCA. Ariel 3, Rucaparib versus placebo, PFS in all the subgroups, OS not significant. Next slide. So the role of PARP inhibitors in management of relapsed ovarian cancers. So after in the later lines of therapy, there has been some controversial withdrawal by the drug makers. So the Ariel 4, Rucaparib, FDA withdrawal of Rucaparib for treatment of BRCA mutated epithelial ovarian cancer after 2 lines of therapy, previous lines of chemotherapy, detrimental to OS with Rucaparib versus chemotherapy. Solo 3, manufacturer voluntarily withdrew indications for treatment in germline BRCA mutant treated with 3 or more lines of chemotherapy. There was no difference in OS for Olaparib versus chemotherapy. Quadra, Niraparib, manufacturer voluntarily withdrew Niraparib's indication for treatment in HRD positive epithelial ovarian cancer with more than 3 or more than previous chemotherapy. Next. So to summarize, recurrent ovarian cancer, CR or PR to platinum-based chemotherapy suspected or confirmed deleterious germline or somatic BRCA mutant, Niraparib, Olaparib or Rucaparib, while BRCA wild type HRD negative and previous bevacizumab with chemotherapy, bevacizumab maintenance, and other option is observation. Next. So thank you, and that is all we have, and over to the organizers.
Thank you, Dr. Priyanshu, for that wonderful talk. So in your clinical practice, how is your experience with the usage of maintenance PARP inhibitors?
So maintenance PARP inhibitors, I think that's a little bit of tricky thing. So a lot of my patients usually do not tolerate the full dose, and especially if they are HRD positive. And so the use was limited by cost till now, but now with generic, so we are using more and more of these drugs. And I think toxicity with the innovator was pretty much. So we'll see how it goes with the generic ones.
And out of rucaparib and olaparib, which PARP inhibitor you end up using more in your practice?
I've used olaparib only. I'm not
You
using
use
rucaparib. Because
Thank you.
rucaparib, I think that the data is very recent in the first line. Thinamono has come recently.
Thank you, Dr. Priyanshu, for your wonderful talk. Now moving on to the next part, that is a panel discussion on management of advanced ovarian cancer. And the moderator for this session will be Dr. Deepak Bharati. He's a consultant medical oncologist and hemato-oncologist at Shri Mata Vaishno Devi Narayana Super Speciality Hospital, Katra. And I also welcome his panelists, Dr. Suresh Patel, consultant medical oncologist at Capital Hospital, Jalandhar, Dr. Deepak Singla, we all know, Dr. Imran Khan from Fortis Hospital, Mohali, would also join.
And yourself also.
Yeah, that is why I'm not switched off my video.
Okay. Good evening.
Good evening, Dr. Deepak.
Good evening.
Yes, good evening, Deepak. How are you?
Fine, sir. Good evening. How are you?
Good, good.
I think my slides are visible.
Very much visible. Start.
Okay. So basically, we know everything about the ovarian cancer, but my topic of discussion this thing only, there are certain clinical points, how we are using certain lab parameters or certain testings in the present scenario, and how we are making all of us wiser in all the things. So we will start the things. The routine 56 of female come to us with APD symptoms and abdominal distensions, and we have done the routine CT scan. Solid cystic masses with iliac nodes or mental deposit, moderator sites is there. We have done the histopathology, it's come high grade serous ovarian carcinoma. So after that, we have seen that. Okay. So number one, I think Dr. Suresh is there. Dr. Suresh is available or not? Dr. Suresh, I think he's not here. Okay, no problem.
Dr. Suresh is here. Yeah.
Yes, Dr. Deepak.
Yes, good evening, Dr. Suresh. I just want to, one thing, how will you approach this case in the present era? How will you move forward? This is what we have done. We have done the CT scan, test of abdominal pelvis. We have done the histopathology. Marker is raised. 56 or female.
Dr. Deepak, can your sound be little loud? Actually,
Okay.
I'm not able. I think some issues with the audio.
Of mine or yours?
From your side, yeah.
Okay, no, it's
now it is audible, yeah.
Okay, so please tell me that how will you proceed with this case?
Okay. So biopsy has already been proven. It is high grade serous ovarian carcinoma and advanced stage. So we will have a multidisciplinary team discussion, and then most probably our option will be to go for neoadjuvant chemotherapy.
Okay, reason behind that, is there any scientific data about that? It's only for surgical to make feasible, or it's some overall survival benefit?
Actually, it is stage 3 disease with ascites and even omental deposits. So better to go for neoadjuvant therapy before proceeding for surgery.
Okay, fine. So this is all the parameters there with CA125-1158. As we all know that whenever patient has ascites, it has come into stage 3C, and we know that NHCT, we agree that we can go for that. But whether NHCT will convert into survival benefit is not, it's still a debatable question. But most of surgeons want us to give chemotherapy and they'll do a sandwich surgery for that. Okay, so my portion is that whether there are certain patients where even in stage 3B or stage 3C setting, we can go for primary debulking surgery upfront, or still NHCT is standard of care for this stage. Dr. Imran? Dr. Imran?
Dr. Imran is not there.
Okay, no problem. So, Dr. Chitresh, I just want to know from your end, there are certain patients where we
So,
see
on a day-to-day basis, generally we end up discussing this in tumor boards, and most of the surgeons, they would advise for favor of neoadjuvant chemotherapy if patient has mild to moderate ascites.
Okay.
But if you ask me from the scientific viewpoint, I think there are very specific indications for offering neoadjuvant chemotherapy. So generally, a patient who has a disease which is going to involve a large resection, below diaphragm, the nodes above diaphragm, or the intrahepatic parenchymal involvement, or massive ascites. So these or the performance status does not allow.
Okay.
So there are certain indications where we should definitely go for neoadjuvant chemotherapy. But in day-to-day clinical practice, I feel that it is more of a discussion between your medical oncologist and surgical oncologist and the primary performance status of the patient. Because ovarian cancer, if a patient has ascites, the appetite is very low, the performance status baseline is not very good, and not all surgeons are very comfortable offering such an extensive surgery upfront.
Okay. So this is what we all are talking about, that ascites or say 3B is not only the indication that we can go offer NSCT. It is more of a surgeon condition that they want us to give chemotherapy to debulk the disease, but without any survival benefit. So there are certain indications: bulky abdominal disease, Metz-Pota, carcinomatosis, or stage 4 of multi-bowel dissection anticipated. These are certain things where we have to offer NSCT as compared to primary debulking surgeries, and the certain patient points are there. So these are trials which are shown that NSCT and PDS is non-inferior. Anything can be chosen. It is majorly a surgical decision that they want to debulk and they get the surgery in a proper way. But no trial have shown any benefit for these things. What Dr. Chitresh told us. So regarding all this, these all trials are for stage 3 and 3-4. So everything is non-inferior. Okay, so patient are not for suitable upfront surgery, as we know that our surgeons choose the things and they have underwent NSCT. Dr. Singla?
Yes.
So there are two things. Obviously, we know that we have to offer these things to our patients. What schedule you are offering to our patients? Weekly or 3 weekly? And what drugs?
Yes, as this patient was having moderate ascites, majority of the time, to practically, I offer weekly. I offer weekly chemotherapy because of,
Okay.
sorry?
Okay, fine. Please continue.
Yeah, because majority of the patient are having a PS of 2 or 3. Okay, between the 2 or 3, and and their nutrition status and everything, they are majority of them are malnourished and moribund. So I prefer them first cycle to be given weekly, and later on, if the patient is comfortable, we can give the option of adding bevacizumab and switching it to the 3 weekly. So this is my general practice majority of the time.
So we are absolutely right that we have to tailor our treatment as per the patient performance status. But what the old thing is that regarding the chemotherapy, especially for ovarian, 3 weekly, little bit I think superior to as per the weekly, but we have to tailor the disease as per the patient. Whether you will add VEGF or not.
Yes, I would definitely in the moderate ascites, I will definitely not from the first cycle, but from the second cycle, I will definitely add.
Okay, so I think ascites is the only criteria for NSCT to put this thing. If someone is with stage 3 with no ascites, are you happy without a VEGF, or you still want to add VEGF in certain conditions?
No, I will still add in the stage 3 and stage 4. I will definitely add VEGF.
You definitely add the VEGF with the bag. I just want to hear from yourself that whether you want to continue this thing after completion of all the things in maintenance setting, or you want to give it in the neoadjuvant setting only.
Sorry, repeat it once again, Deepak.
You want to continue the VEGF after completion of adjuvant, neoadjuvant for 1 year of either ICON or GOG, or you want to give only for the surgical point of view only for 6 cycles only, or for 3-4 cycles only?
No, my criteria for the maintenance will be depends upon the after the result of the cytoreductive, whether it is a R0 section or R1 section, and what was the what was the viability of the tumor whether it was what was the grading of the chemo response, okay, to the tumor. If it is fully, if there is a viable tumor after giving the chemotherapy also, so I will definitely like to the maintenance. I will go for a maintenance VEGF, and if there is suboptimal surgery, then also I would like to go for a maintenance VEGF inhibitors.
Okay, so your point of concern is that if someone in CR with good chemo response, you will stop the treatment. If someone with less chemo responsive and some viable tumors left behind, you will continue VEGF. Good.
Yes, yes.
Okay. So number 2, Dr. Suresh.
Yes, Dr. Deepak.
What about genetic testing? As in, this is the topic of discussion in the present our moderation session. That I want to hear from your side.
In my practice, I usually go for somatic BRCA 1 and 2. Although I offer the option of HRD also.
No.
But in my practice, I generally go for.
So my point is that you will offer HRD if someone is go for that is okay with you. If or you minimum want somatic BRCA 1 and 2.
At least I go for the somatic BRCA 1 and 2.
Okay, and you want to this in the surgical specimen at this point of time only?
Usually we don't have data regarding which specimen we should go for, but if I usually prefer going for initial biopsy specimen.
Initial biopsy. Okay, fine. So Dr. Chitresh, you want to differ, you want to add something regarding genetic testing, whether for a biopsy specimen or surgical specimen, or which test you want to order, whether a full HRD or some germline or somatic or both combination reflex?
So I think ordering at least somatic BRCA1, BRCA2 would make sense.
Okay.
HRD is an additional bonus.
Okay.
And if the cost allows, then definitely I would like to have it.
Okay.
Then
lot of coupons are there with you. You can use anything.
But still, with coupons also, it is an expensive test.
I think Astra is providing free of cost. They have stopped the thing after this generic, or still funding with that.
So we have to find it out. But for a patient who it is a costly test. And for the specimen part, I don't know of any difference in the outcomes based on whether we do it on a biopsy or on a surgical specimen.
I guess this is a personal question. Which panel you are ordering and from which lab, or there's any lab you can prefer, or some specific lab is there where you need that?
So if I get a coupon, then that lab.
Okay, fine.
If I get otherwise, MedGenome, I think gets a good report in my practice.
Okay, fine. So that's all from their side, that the role of genetic testing has come up in the adjuvant emergency setting also, because whenever trial of this olaparib maintenance come up for 2 years, this will make us more understandability. If someone is get positive for BRCA1 or 2, whether somatic or HRD, we have to give the benefit of olaparib to these patients for 2 years. Okay, so obviously we have to do genetic counseling and
So
testing.
I will just like to ask one question. Sorry to interrupt.
Fine.
Like Dr. Deepak mentioned that he would like to add bevacizumab from second cycle. So
Yes.
how practically is it not challenging that you have to wait for 28 days prior to surgery? After giving bevacizumab, so you add on cycle 2, you would.
Yes, I got your point. Dr. Chitresh, I mean, it all depends on the performance status of the patient. Okay. If the patient is, PS is good, I mean, I can add it from the, first week or second week on.
Okay.
So some point is that basically after 3 surgery we have to do the surgery. In the 3rd cycle we have to skip the bevacizumab. Even if we skip the 1 more dose, only 1 dose we are left for the getting the response. The point is that we have to add bevacizumab from the 1st cycle only, so that patient will get the minimum 2 doses prior to the surgery after 3 cycles.
Usually first cycle, generally some people don't add because there are chances of obstruction. So due to extensive abdominal disease.
That is all depends on
most of them go for from second cycle also, but we have to stop around 6 weeks before surgery.
Okay, fine. So this is a multi-centric study for BRCA1, BRCA2, Center Rajapal, Dr. Sudeep and Dr. Amit Agarwal, Dr. Suresh Mane, all are there. They have shown that out of 239 patients, 21% possibility is there, and even on 4% are not able to do whether they fall into which group, and 67% have no history of family is there with the BRCA1, BRCA2 germline. So patient has got good response after 3 cycles, underwent debulking surgery.
Yes, yeah. Am I audible? Sorry, I mean, it got disconnected from my end.
Okay, no problem. So Dr. Deepak, there's one question from you. whether you will add HIPEC at this point of time or not. Are you happy with HIPEC or not?
I mean, when to add HIPEC? Sorry, can you repeat your question, please?
The patient has taken 3 cycles of NACT. After that, patient has planned for surgery by surgeon. Surgeon want to add HIPEC with that. Are you okay with that or not?
HIPEC due to what? I mean, if there is no intestinal involvement, no gut involvement, why to add? I'm not very comfortable in adding HIPEC.
Okay.
No.
So you want to use in the recurrent setting only HIPEC, or you don't want to use HIPEC in any indication for ovarian cancer?
And not in the upfront, unless there is,
Okay.
they do it, but
Okay.
there is no concrete data to suggest that it has
Okay.
HIPEC.
Dr. Suresh, your take on HIPEC in upfront setting or in recurrent setting?
Yes, Dr. Deepak. If better if we had a surgical oncologist on the board today also in the meeting. But
No problem.
I
You
usually
say-
go for HIPEC in cases of patients with extensive abdominal disease. But unfortunately, we don't have a HIPEC facility at our center.
Okay, no problem. So I just want to add my points. Basically, what we did, there's something PCI is there to rule out HIPEC. Whenever we are giving the chemotherapy, we value the patient in the name of scoring of PCI. If someone with low score is there, they are the one who will get the more benefit for HIPEC. And low score, I mean less than 9 or less than 12. Anything is less than 9 or less than 12 is there for PCI. These are patients where we can add HIPEC in upfront setting also. Although we are very much comfortable for recurrent setting only, but this is the indication as per the NCCN. Dr. Chitresh, you take on HIPEC. Anything you want to add or you want to discuss?
Evidence is there, but practically it is a very, very challenging thing to do.
Okay.
Because number one, it adds to the cost of the treatment.
Yes.
Secondly, recovery from the surgical aspect after HIPEC sometimes is very difficult.
Okay.
And sometimes we miss on the proper delivery of the adjuvant treatment if a patient has undergone HIPEC in the primary debulking.
Okay, fine. So,
So I don't think.
are you using at your center?
So we have couple of patients who have undergone HIPEC at referral centers at Delhi and come back to us. We had experience of around say 4 or 5 patients, but most of the patients have not tolerated them well, and 1 or 2 patients have to compromise on the adjuvant treatment because of the complications and the cost they incurred during HIPEC.
So my question is that if patient has come to surgeon and surgeon plan that we do surgery plus HIPEC and patient comes to you back. So doctor, you are my primary doctor. What do you take on that? Whether I would go for that or not? What do you say? You say no, or you would want to take?
Despite the data being there, I would not go very strongly in favor of HIPEC at this point in time.
Fine. Okay. So this is what is there. The OVHAP study is there, which has come into limelight for stage 3. These are survival benefits, what they have shown, but 33 versus 45, 12 months more survival benefit, and it is there in the guidelines for 2021. They have used cisplatin 100 mg per meter square at the time of interval or in any time up in stage 3 settings. So regarding adjuvant treatment, we know we have to complete the 3 cycles of chemotherapy. Again, I want to hand Dr. Chitresh, if someone has offered bevacizumab, we already continue with that also. Whether you will want to continue with maintenance bevacizumab or you want to differ.
So see, if I have started bevacizumab in the neoadjuvant setting, I would continue it in adjuvant and the maintenance therapy.
Okay.
Though I understand that the OS advantage is not there with the usage of bevacizumab in all subgroup of patients, but PFS advantage is there, and for patients who have high risk, suboptimally suboptimal cytoreduction, even in those patients we can get an overall survival advantage. So if a patient is able to tolerate bevacizumab, there is no side effect and the cost is not a major issue, then I would be happy to continue this in the maintenance phase.
Okay, fine. So I think all the points which Dr. Deepak Singh has told, we are all agree with that only. So this is the topic of discussion at this point in time. If someone have done the somatic BRCA or HRD, it has come positive. So how many of you all agree with using olaparib, or you want to give any other drug apart from olaparib? Then share some experience with us. Dr. Deepak, your take on that. If the patient of yours are somatic or HRD positive, will you love to add olaparib?
Yes, if the patient is somatic mutation positive and HRD, yes, I will definitely like to have a on the maintenance.
Okay, fine. And if
Olaparib.
someone and as you have used bevacizumab in the initial settings, will you add Ola plus bevacizumab or you want to give olaparib only?
Again, the indication of the using the bevacizumab is different, and if that is also required and that is also required, I can combine both of them.
Combine both of them. So basically, the trial of Ola for Ola plus
Ola one.
bevacizumab. So basically, there's come a role of HRD only. It has not been done on the basis of BRCA1 or BRCA2. If someone is HRD deficient, then we can add bevacizumab if we have used prior to that. Dr. Suresh, your take on any experience of using maintenance PARP inhibitor, or you want to differ with any of the PARP? You want to do rucaparib or niraparib, or you want to stick with olaparib only?
So my experience with olaparib is not great because
Okay.
my patients do not
Dr.
tolerate the prescribed dose.
Dr. Chitresh, in this setting or you want to setting or a routine setting you're talking about?
So
Especially
any
for this
setting you take, any setting you take.
Okay.
So there are certain patients who are doing well on rucaparib,
Okay.
but I cannot count more than 1 or 2 patients who have done well on olaparib.
Olaparib. Okay, fine. So minimum, even after decreasing the dose?
Yes, so full dose I have never reached only. I start with 300
Okay.
milligram.
So they have stashed with that. Dr. Suresh, your take on that, and you want to differ, you want to add something or from your experience?
Regarding in my practice, I give the option of PARP inhibitor as maintenance therapy for patients who are BRCA positive.
Okay.
Regarding combination therapy with olaparib and bevacizumab, I have started one patient, but due to toxicity, then
Okay.
I stopped bevacizumab and continued olaparib only in that patient because toxicity is the major concern in the
And
combination therapy, especially hematotoxicity.
so
So
you have stopped olaparib or you have stopped bevacizumab?
I have stopped bevacizumab.
So what toxicity she had?
Especially thrombocytopenia. So which was grade 3. So I stopped bevacizumab and continue olaparib only in that patient.
Okay, so that's basically the hallmark is that the point we have to do genetic testing, either somatic or HRD, if someone can prefer for that thing. If someone have already started on bevacizumab, then we have to add bevacizumab. It's the direction of the physician, or else we have to start with olaparib only. Nobody, I think, luckily to start rucaparib or niraparib in the maintenance setting in the present era. Okay, so patient has taken olaparib for 2 years. No evidence of disease was there. For how long to continue? You want to stick with the trial or you want to continue as the patient will little bit nervous? Dr. Chitresh, if
I
someone
would
of
like
the
to
patient
stick with the trial.
okay, fine. So after 1.5 years after the completion of olaparib, patient is starting the recurrence in the form of rising CA125 with pelvis decline has come back. So a role of secondary cytotoxic surgery. Dr. Singla.
Yes, disease is, CA125 is 120 and recurrence is where, Deepak?
Pelvic, only local pelvic recurrence.
Okay, pelvic recurrence. All right. And how big it is in the pelvic recurrence?
Just a small thing is there, just a small bunch of pockets. Just see the yellow line. It's just this is the recurrence. Let's see.
I would like to first of all confirm that whether it is whether it is a real recurrence or not, or it is simply a biochemical progression.
Okay.
We would like
Okay.
to go ahead with the FNSA.
Okay, you have done the you have done the surgery. You have done the biopsy. It has come again high grade serous. Then what you will do?
So it's a recurrent setting, and it's a very tricky question. So we can go ahead with the secondary CRS upfront as well.
Okay, fine. Still you want to do CRS or you want to add HIPEC at this point at this indication? No HIPEC.
HIPEC, no. For this recurrence, that much of recurrence HIPEC, I will not prefer.
Okay, fine. So these are the certain trial desktop 3 COGS associate all has shown that with chemotherapy everything is there. There's some benefit or with ratios everything is there. So we can go with the all the statistics. Dr. Suresh, your take on secondary cytotoxic surgery, and you want to add HIPEC at this setting or not?
I usually we do have data for secondary cytoreductive surgery. As per the AGO score, if it is only local recurrence, then and also it has some criteria regarding omental metastasis and even ascites. So as per that, we can offer the option of secondary cytoreductive surgery. Other option, we can go for second line chemotherapy also in this patient.
So no surgery, only chemotherapy.
If surgeon is ready, that we have
Surgeon-
data for secondary cytoreductive surgery. If
Surgeon
he's
is al-
ready to operate,
surgeon
then
is
I will
already-
go for surgery. Otherwise, I will go for second line chemotherapy in this patient.
Okay, so Dr. Chitresh, you are agreeing with what his Dr. Chitresh is saying, that we can skip surgery, we can go for chemotherapy.
So see, what I understand is that secondary cytoreductive surgery in this patient should be beneficial because the time interval has been more than 2 years. It is an isolated pelvic recurrence. We have to ask the surgeon whether R0 resection would be possible or not. But looking at the scan, I think R0 resection would be possible.
Yes.
So, seeing the volume of the disease, the possibility of an R0 resection, and the time interval of more than 2 years, all
Okay.
this, encourage me for consideration of a secondary cytoreductive surgery.
Fine.
But the final decision would obviously be with the surgical oncologist.
Okay, that's fine. And you have already explored the option of HIPEC, as you told me. So I just want to add one more thing. Will you add adjuvant chemotherapy?
Yes, I will.
You will. Okay. Full 6 cycles?
Yes.
Okay. So patient underwent CRS, RO resection is dead. Adjuvant treatment, you have told that we can give that. And definitely there's a data of bevacizumab maintenance is there, the OCEAN and other trials, as was not in adjuvant setting. I think everyone will go with the same chemotherapy pattern with the addition of bevacizumab and maintenance setting. What I feel, and I think everyone will just Dr. Chitresh, Dr. Singla, Dr. Suresh, we will definitely add bevacizumab if someone has not continued for 1 year after that. Dr. Suresh.
So bevacizumab can be offered. There is no contraindication.
No problem. Okay, fine. So these are
I want to ask whether we go for which adjuvant chemotherapy, taxane plus platinum based.
Definitely.
So it's more than 2 years. It's a platinum sensitive disease. Probably paclitaxel should be a
Platinum
rechallenge.
we can go, sir, but paclitaxel.
But Dr. Suresh, number one patient is BRCA positive, BRCA mutant. Patient has olaparib. Patient has taken 2 years olaparib, 1.5 year DFS after that, touching 3.5 years. And I would think everyone will go with Pacli and taxane and this thing. What you want to add with the
But I want to just ask regarding what is the duration which you follow for any patient. Patient is 2 years post 2 years therapy, but what is the exact duration you follow for paclitaxel re-challenge?
1 year. Everyone follow 1 year. 1 year. I think Dr. Chitresh, Dr. Singla will agree with that thing. I think everyone will go with 1 year only. Yes, Dr. Singla.
Yes. I mean, it appears to me it's a platinum sensitive disease with a TFI of more than 2 years. So same therapy, if there is no contraindication is present, so the same thing can be rechallenged.
Okay, so there's a common next question. Everyone is happy with chemotherapy with bevacizumab. No patient with a stoppage of olaparib for 1.5 years. Will you re-challenge maintenance olaparib? Dr. Chitresh?
Sorry, I got a call. Please repeat your question, Dr. Deepak.
So everything has been done, surgery done, chemotherapy done, bevacizumab maintenance, they are planned, and we know background patient is BRCA mutant. Will you give maintenance olaparib re-challenge?
So some data, but I am not too sure about it.
So you want only give bevacizumab only. Dr. Suresh, you add olaparib with a background of HRD positive with 2 years of maintenance setting.
Yes, we should offer the option of maintenance olaparib in this patient.
Okay, fine. Dr. Singla?
I'm not very sure.
No one is sure about that thing because patients are taken for 2 years and just 1.5 years left behind.
Because patient is already received the 12 cycles of will be completing the all 12 cycles of total of chemotherapy. I mean, chances of getting toxicity with PARP inhibitor will be quite high because of the poor marrow reserves. So I won't be very keen to start olaparib maintenance.
Both are right. If someone can start, they can start. If not, both are equally right. At this point of time, I think most of us will go with residual maintenance only, and we wait for next recurrence. Then at this point of time, we will keep our reserve for olaparib to use for future settings. I think everyone. So one size fits all. Thanks a lot for all the things. So there are 2-3 things which we want to discuss, like the role of olaparib, like genetic testing with the use of bevacizumab, adjuvant or recurrent setting, and with HIPEC. I think these are 4 general questions which we routinely handle in our day-to-day practice, and I want to highlight all these 4 points. And all of you have answered brilliantly with all your experience, what is there in your center. And that's all from my side. If something is there, let me know.
Dr. Deepak,
Yes.
I would like to ask whether anyone has used what we say poor man's bevacizumab, which is pazopanib maintenance therapy. Although they have recommended category 2 in
Sir,
NCCN guidelines.
There are 2 things, like in metronomic
Any
therapy, we know
experience
that
regarding that?
there's a metronomic therapy data of etoposide and pazopanib is there, and most of us we are using that way also. And you ask me single agent pazopanib in the later lines, either in 3 line, 4 line, or 5 line, 6 lines, most of us are giving pazopanib. Nobody can give pazopanib in the second line or third line. It is at the end of a time a patient will get, we have to give some PFS to our patients, and we are using that because we know pazopanib can work in the form of VEGF, and it can cover the VEGF component also, and some sort of metronomic therapy. And we are using, but not in the initial settings, but keep this thing for later lines. Dr. Chitresh and Dr. Chitresh asked some question. Where you want to use pazopanib, or you still want to avoid that?
So in my practice, very limited role.
Very limited role.
And
But we have seen that because being an oncologist, we see that pazopanib work in the form of VEGF inhibition. VEGF also, we know that it will somewhat act similarly and gives benefit to our patients. It's very hypothetical to correlate the thing.
Main reason for this is that we know bevacizumab is a very costly drug, and in India, definitely cost is an issue. So I was just asking. Many of the people can't afford VEGF bevacizumab for a duration of 1 year also. Most of the insurance limit they reach.
There's one in-house trial of AIIMS where they are using etoposide, cyclo, and pazopanib. All the 3 drugs in one go. So we have seen some wonders with that also, but it is not logical, and we've not seen any routine things. There are anecdotal cases where they can give 8 months, 9 months, or 1 year benefit, but like that. But one trial is there from AIIMS with ECP. Dr. Lalit has done that. So anything more from the in-house?
So I do have one question that I have, again, as Dr. Suresh said that 3-4 years back, when the generics were not very commonly rampantly available, I used to use this pazopanib, and few of my patients responded very well. Although I couldn't reach the standard dose of 800 mg in majority of the patient, but at the dose of 400, 600 also they did very well, and I don't know. The disease were under control for a quite good time. And I do have one question in maintenance. What dose of bevacizumab you use? How much mg per kg you use?
So there are 2 things we know: ICON and GOG, 15 mg per 7.5, and basically it's all depend on finances. Which trial you want to use? We are using flat. If you ask me, it's flat 400 or maximum 600 is there for our patients. For some, if someone is not affording, otherwise I'm going for 7.5 mg per kg only.
Sorry, 7.5.
Yes, sir, 7.5 mg per kg.
Okay, right.
And even I agree with many oncologists do give the standard dose 400 mg also in the patients. Although there is no data of this dose, but many people give fixed dose of 400 mg in also as a maintenance therapy as a routine practice also.
Thank you, Dr. Deepak, for that wonderful panel discussion. And I thank Dr. Suresh, Dr. Deepak Singla for a very, very interactive session. So moving on to the next session, that is the hematology session, the session sponsored by Roche. The topic is optimizing management of previously untreated DLBCL with Polivy. And to talk on this, we have with us Dr. Davinder Paul, who is a consultant medical oncologist at Fortis Hospital, Ludhiana. So I welcome Dr. Devinder Paul and request to give his talk.
Yeah, good evening. Am I audible?
Yes, you are.
So thank you, Dr. Chitresh, for inviting me for this talk. And without wasting any time, I think I will start the talk. So I'll be talking about the new drug on the block, polatuzumab vedotin, Polivy. This is in the treatment of previously untreated diffuse large B-cell lymphoma. Next slide. So we all know that the first-line treatment of diffuse large B-cell lymphoma, which is a high-grade B-cell malignancy, it started in 1976 with the formulation of CHOP, and fortunately or unfortunately, this remained the standard of care till 2000, early 2000, and the last years of this last century, we came to know about the drug, which is one of the first monoclonal antibodies to be used in oncology. Rituximab came into picture, and this translated into additional PFS benefit of around 15% across all the stages. And after that, it became the standard of care. And for the last more than 20 years, this regimen had remained the standard of care. People have tried multiple things. We all have tried multiple things. We have used aspirated VCOP. We have used, EPOC. We have used certain other molecules also. But all the trials showed that the R-CHOP was the standard of care. And this drug came into picture in 2022 with the invent of polatuzumab. Next slide. So polatuzumab is basically antibody drug conjugate ADC, which is now quite frequently used in many other things, many other malignancies. So it is an ADC which is targeting the CD79 that is designed to provide delivery of a potent anti-microtubule disrupting agent called the monomethyl phosphate directly to the B cells. And this polatuzumab consists of a potent microtubule inhibitor, that is MMAE, conjugated to a CD79B monoclonal antibody via protease cleavable peptide driver. So in this regimen, we are replacing the vincristine in the R-CHOP with the polatuzumab, and this increases the efficacy without significantly increasing the toxicity for the patients. And CD79B is a signaling component, which is a component of the B cell receptor, and it is expressed on normal cells within the B cell lineage and malignant B cells also, but not on the plasma cells and the other vital tissues. So this is the way in which this drug basically occurs. It binds to the receptor, gets internalized, and the potent microtubule chemotherapy part is sent into this, and that leads to the cell kill and the apoptosis. Next slide. So this is the trial, POLARIX trial. It was a global randomized double-blind placebo-controlled trial published in NEJM in 2022, and we'll be discussing about this only. Next slide. So in the POLARIX trial, we had two arms. The modified regimen called the polatuzumab plus rituximab plus cyclophosphamide plus doxorubicin and prednisolone, and the standard regimen is the R-CHOP. Almost 440 patients were equally divided in both the arms, and 6 cycles of this regimen were given at the interval of 21 days. Next slide. So the POLARIX trial is, as I told you, it's a randomized double-blind placebo-controlled phase 3 trial. A sample size was around 879, age up to 80 years, IPI of 2 to 5, regardless of cell of origin, or in the presence of any rearrangements. All the patients were taken to this, stratified for IPI 2 to 5, bulky versus non-bulky, and geographical regions like West versus Asia. And CNS prophylaxis was permitted as per the institutional practice. So 6 cycles were given in both the arms, and after that, the primary endpoint was the PFS, and the key secondary endpoint was the event-free survival, and the PET-CR at the end of treatment, and overall survival and safety. Next slide. So the POLARIX trial included a proportion of high-risk patients. The patient, they accounted for almost 1/3 of the patients had ABC type of DLBCL, and almost 2/3 had an IPI score of 3 to 5, and almost half had bulky disease. And you can see even the expression, the MYC3 and BCL2 expression, that is double expression, and triple hit expression, they were also equally randomized. Next slide. So the POLARIX met its primary endpoint of PFS. This trial met its primary endpoint, demonstrating a statistically significant and clinically meaningful prolongation of PFS with the addition of polatuzumab versus the R-CHOP. The observed PFS HR of 0.73 translated into a reduction of the risk of disease progression or death by 27% in the polatuzumab arm compared to the R-CHOP. And on the basis of the Kaplan-Meier estimates, what this also means is that the treatment with polatuzumab resulted in a higher proportion of patients who were progression-free at 2 years compared to the R-CHOP. You can see at 2 years, there was a difference of almost 7%. Next slide. So PFS benefit with the polatuzumab versus R-CHOP. The benefit was maintained with a longer follow-up with the PFS increment of 7.7%, as I told you, at even 3 years. And the majority of PFS events occurred in the first 2 years, only 3% in the third, and only 3% happened in the third year, with more PFS events in the R-CHOP, you can see. So this demonstrates superiority and durability of PFS response by polatuzumab over the R-CHOP. And almost 90% of patients who were progression-free at 24 months, they remained progression-free even at 3 years also. So this proves that the PFS at 2 years, that is 24 months, is an important landmark for the DLBCL patients who are treated with the first-line treatment. And this can be taken as a surrogate marker for the overall survival in such a curative setting. Next slide. So the cumulative incidence of even the patient who had a primary refractory disease, the incidence of primary refractory disease was also less in the polatuzumab arm compared to the R-CHOP. You can see 22% in the polatuzumab arm versus 29.7% in the R-CHOP. So the use of polatuzumab also led to a lower cumulative incidence of primary refractory disease, which we all read, and as compared to the R-CHOP by almost 7%. Next slide. So you can see the event-free survival. The positive results of the primary endpoint was also supported by the secondary endpoints. The event-free survival, for the efficacy reasons, showed a significant reduction in the risk of occurrence of disease by almost 25%. You can see at 24 months also, the EFS was much better in the polatuzumab. Next slide. Coming to the PET-CR at the end of treatment DFS, a higher number of patients achieved a PET-CR at end of treatment. That was almost 78% in the polatuzumab arm compared to 74% in the R-CHOP. And the CR and the overall response rates are important objectives. So because the CR at the end of treatment, that is around 6 months, is a step towards cure, but it requires durability beyond 24 months to translate into a cure. So the durability of CR was improved with the polatuzumab, and as demonstrated by the DFS benefit with HR of almost 0.74. Next slide. Coming to the overall survival, overall survival data did not meet statistical significance. The POLARIX trial was not actually designed to look for the OS benefit, and it was a secondary endpoint. However, PFS is established and well-accepted criteria for OS surrogacy and is a valid endpoint. So given the immaturity of the POLARIX current OS results, which can measure the treatment effects, the POLARIX of this trial, the other secondary endpoints take a greater importance to supplement the PFS observation and benefit. Next slide. So coming to the risk of requiring second-line therapy, even with the use of polatuzumab upfront, there was less patient who required the second-line therapy. The cumulative incidence of second-line therapy at 2 years in the polatuzumab arm was 17.1% as compared to 24.4% in the R-CHOP arm. So based on the ad hoc analysis evaluating the potential impact of polatuzumab on the second-line therapy, so using the results from this study, it can be projected that the use of second-line therapy after the use of polatuzumab is less, and this can lead to slightly less patients who can go on for second-line treatment. We all know the second-line treatment in our setting, they are quite costly, and so more patients were being treated with the polatuzumab, and less patients are going to the second-line treatment. Next slide. So coming to the investigator assessed PFS, the subgroup analysis, you can see all the difficult to treat patients like the elderly patient, IPI high patients, the ABC histology, and the presence of double expression. All these patients, the high-risk patients, we all know they are difficult to treat, and they all had a substantial PFS benefit at 2 years with the use of polatuzumab as compared to the R-CHOP. So all the difficult to treat patients gained higher benefit with the use of polatuzumab. Next slide. Coming to the same thing, the cell of origin subgroup, there appeared to be a significant benefit in the ABC subtype with the impressive HR you can see of 0.34 and a 2-year PFS rates of 85%. So we all know that ABC subtype has always been a difficult to treat subgroup, and which also reflects here at the 2-year PFS with the arch of 56%, which is we all know that with the second it's around 50% with the arch of only. So next slide. Another high-risk patients, elderly subgroup, the risk of progression, relapse, or death was lower with the polatuzumab as compared to R-CHOP. In these patients, the OS data was immature but showed a trend to reduction in the risk of death with the use of polatuzumab. And you can see the risk of progression, relapse, or death was lower with the polatuzumab. And data is relevant because elderly patients are usually not candidate for auto transplant or second-line therapy or any other high-risk, high-dose chemotherapy. So the use of polatuzumab in the elderly patients is quite a good option to have. Next slide. Coming to the safety results of global population, which was data cutoff was done at 28 June 2021 in this trial. Next slide. Yes, so study drug exposure overall 91.7% and 88.5% of polatuzumab versus the R-CHOP patient received 6 cycles of treatment, that's full dose, a full cycle. 89.2% and 86.3% of patients treated with polatuzumab versus R-CHOP respectively received all 8 cycles of treatment. And the median relative dosage intensity of rituximab, doxorubicin, and cyclophosphamide were more than 99% in both the treatment arms. Next slide. So safety profile of R-CHOP versus polatuzumab. You can see that the dose intensity could be preserved in the polatuzumab arm, and there were even less discontinuation reduction versus the R-CHOP in which the vincristine was used. So you can see discontinuation because of any drug, study drug. You can see it was 27 in the pola arm versus 6.2% in the polatuzumab arm versus 6.6% in the R-CHOP arm. Peripheral neuropathy was most common AE in both the treatment arms, and a higher grade of neuropathy was less in the polatuzumab arm as compared to the R-CHOP. And AEs with a difference of more than 5% in incidence between the pola arm versus R-CHOP were diarrhea and febrile neutropenia. Next slide. You can see adverse event of the pola arm CVP any grade on grade 3 or 4. You can see on all the accounts, whether it's a peripheral neuropathy or nausea, both are better in the pola, or both are less with the polatuzumab. And regarding the neutropenia also, it was less in the polatuzumab arm. Slightly more diarrhea was seen, and slightly more anemia was seen with the use of polatuzumab. But the grade 3 or 4 toxicity was less. Next slide. So taking all this data into consideration, the NCCN guidelines have revised the 2024 guidelines for the diffuse large B-cell lymphoma. You can see stage 1 and 2, excluding the stage 2 with the extensive disease, polatuzumab and rituximab RSP is now the category 1. And also in the patient with extensive disease, this is one of the options to be used, although R-CHOP remains one of the category 1, but also the use of pola RSP is also there. In other patients who had a left ventricle dysfunction, you can see we use multiple things. We have multiple chemotherapy options, but even in these patients also we can use the polatuzumab. And very frail patients, with patients of more than 80 years of age, we all know they are very, very difficult to treat, and people are using multiple things, and even polatuzumab plus polatuzumab plus bendamustine can also be given. So this is slightly a gray area, and it all depends on the treating physician or medical oncologist how to proceed further. Next slide. So the impact of this trial, the POLARIX is the first trial in over 20 years to show a meaningful improvement in the benefit risk profile over R-CHOP in an international phase 3 double-blind randomized controlled trial. This trial reasonably accomplishes the goal of treating the first DLBCL patient by improving the disease control and avoiding toxic, costly second-line salvage therapy. The benefit of polatuzumab holds even more importance in the setting with the limited access to newer efficacious treatment in the later lines, like the CAR therapy or the autologous stem cell transplant. And because of this, POLA RCHP is now the category 1 preferred regimen as per the NCCN and also the other guidelines, and is also recommended with NICE guidelines and many other guidelines also. So next slide. So that will be all from my side. Thank you so much.
Thank you, Dr. Davinder, for a wonderful talk. So moving on to the last session, that would be a panel discussion on treatment decisions in first-line DLBCL. So to moderate this session, we have Dr. Sandeep Kukkar, who is Director Medical Oncology at Sohana Super Speciality Hospital, Mohali. And I would also like to request his panelists to join Dr. Hakim Ansar Hussain. He's a Senior Consultant Oncologist at Fortis Hospital, Amritsar. Dr. Arun Raja, a Consultant Medical Oncologist and Hemato-Oncologist at Capital Multispeciality Hospital, Jalandhar. Dr. Mukesh Bansal, Consultant Medical Oncologist at Alchemist Hospital. And Dr. Deepak Singla from Indus Hospital, and Dr. Burhan Wani, Consultant Medical Oncologist at AOI Jalandhar. So welcome you all and hand over to Dr. Sandeep.
Thank you, Dr. Chitresh. And I think you have organized a fantastic meeting. Thank you for providing the opportunity once again. And I welcome all my panelists for a lively discussion on diffuse large B-cell lymphoma. And I also apologize, I'm traveling with my family, so you might have some sort of disturbance in the network, and I may not be able to communicate. So first of all, how many of you are convinced with the data of POLIVY? Let me ask this question in a different way. How many of you feel that there is an unmet need in treating some of the patients of diffuse large B-cell lymphoma? I would start with Dr. Arun.
Yes, sir. Good evening,
Yes,
sir.
no.
Yes, I'm convinced with the data. I agree to use.
And you feel there is an unmet need in this subgroup of
Yeah,
population?
definitely. DLBSL is always it's like a never filling. What to say? I can't get the words. There
Right,
is no
Dr.
standard of
Deepak?
care. There is no standard of care at present. So it's a evergreen area.
Right, Dr. Deepak. Quickly, Dr. Burhan.
Yeah, good evening.
Yeah, sorry,
I think as has been highlighted by the previous speaker, definitely we have a lot of areas to fulfill still in DLBCL, and we know it is a heterogeneous group, and still we are treating this heterogeneous group with the same line across the various patients. So definitely there is a lot of unmet need as far as the management of DLBCL is concerned.
All right, Dr. Mukesh.
Yes, sir. I think there is an unmet need. The cure rates are not that as high. And as Dr. Buran also said, ABC type, non-GCB type, and other double hit, double expressor, there are a lot of differentiations. We can't treat every patient with the same regime, and there needs to be other better regimes with better curability.
All right, Dr. Hakim. So I think we all agree to this fact.
Dr. Hakim, you kindly unmute yourself. You were not audible.
So has Dr. Deepak joined?
No, I was already there. Actually, I didn't unmute myself.
Right, Dr. Deepak. Please, your inputs.
Yeah. Yes, I fully agree with the data, and especially the subset of the patients, who are very, likely to relapse. Double hit and triple hit patient and c-MYC mutated patient, and where the recurrence rate of quite high. And if we achieve a PFS of 2 years, it will be a blessing for the patient. PFS, and it may turn into the OS also.
Hello.
Right.
Hello.
Yes, please, Dr. Hakim, please go ahead.
Yeah. As we see, the current standard of care is R-CHOP, but it is not very effective. Even in overall population, we see the cure rate of only 60 to 70%. So then to speak of subgroups like ABC and high IPI, cure rate is further, lesser. So we need some more drugs like ADCs which have come now.
Right.
So I
Right.
think
So I would ask another question. Let me take this a bit forward. Before the advent of polatuzumab, what were we doing in our practice to treat this difficult group of population? Because we all know that we all are doing IPI scoring. We are testing for CMYC, BCL2, BCL6 to classify our patient as double hit or triple hit. We all are identifying these high risk group of population. What else do we do before the advent of polatuzumab? What would have been your strategy to treat this group of population, Dr. Arun?
Yeah. So prior to polatuzumab, I will be adding that Model B protocol from UK, that is bortezomib with the R-CHOP.
Bortezomib with the R-CHOP. Okay. Dr. Singla?
No, my my standard of care were R-CHOP.
Or you are happy with R-CHOP?
No, I was adding. I was doing with the R-CHOP. I mean, I was going ahead with the R-CHOP, and majority of my patients were doing well. I mean, with the R-CHOP.
Okay. Dr. Bansal?
I think, sir, there is option of going for R-epoch and dose resisted or full dose, but the results are debatable. There is some benefit in some subset of patients with R-CHOP.
I mean, yes, R-epoch also. I mean, R-epoch I was using, and especially in the mediastinal, MBL type of B-cell lymphomas.
PMBL.
Sorry, yeah.
PMBL.
Yeah, primary mediastinal
Right.
B-cell lymphoma. But in the DLBCL setting, I was using R-CHOP only majority of the time.
Right. So let me go to my next slide. So before the advent of polatuzumab, there were various options. Like we have discussed, it is the augmentation of chemotherapy or adding bortezomib, adding lenalidomide, adding ibrutinib, giving a dose-dense form of treatment, adding rituximab maintenance. But to our surprise, none of it worked. So in my practice also, I have tried ibrutinib in some of the patients, but say for a couple of months, you are happy doing it. But ultimately, the survival benefit, say I cannot comment upon, but the kind of response you see, you want in those high risk subgroup of population, you don't get. So next slide, please.
The slides are not moving.
Not moving.
Slides are not moving, boss. Slides are not moving. Yeah, next slide. These are the unmet need. Next slide, please. So there are certain subgroup of patients, as we have already discussed, high IPI, age more than 60, non-GCB type, double expressors, MYC or BCL2 rearrangements with a very difficult, which are considered to be as a high risk profile and difficult to treat population. Next slide, please. So we have also tried the R-CHOP in different regimens, whether it is ABC or GCB, but we all know that the molecular subtyping with ABC, they don't do that well as compared to the GCB type. Next slide, please. So this is about the risk assessment. We all have been doing it in our day-to-day practice. Next slide, please. So of therapy with adding anti-CD20, augmentation with targeted therapy, changing the chemotherapy backbone, but none of it had worked. So we were looking for an agent that could prove to be a boon for patients with high risk population. Next slide, please. So this is a case, 48-year-old male presented with abdominal pain, lower back pain, and weight loss for around 3 months. Physical examination showed a palpable abdominal mass, flank tenderness, elevated LDH. CT scan showed thickening in the stomach wall with enlarged nodes. Upper GI scopy revealed a large gastric mass where the biopsy was suggestive of DLBCL. So this case was a non-GCB type, CMYC positive, BCL2 positive. Fish was negative, ECOG 1, stage 4 disease, IPI of 3. So this is again a high risk population and a young patient. Next slide, please. So what is our go-to regimen? Like we have discussed about the factors that could prove to be of high risk of recurrence in such a population. And what are the key considerations of treating such a patient? I would start with Dr. Arun. How do you treat with patient? We are not talking about any financial constraints. What would be your go-to regimen and provide the best sort of treatment for this young man?
So in the evaluation, I used to add that the PET-CT as a biomarker because the tumor burden will be assessed properly with PET-CT based things. So it's a higher IPI. So naturally, I will just the previous standard, UK standard was bortezomib with R-CHOP. So that was my prior go-to regime before the
Right.
advent of polatuzumab. That's my
Okay.
practice. So
Right.
even a cell of origin or whether fish positive or negative doesn't matter, but
Okay.
that has a PFS and OS benefit. So based on that role model B data, so I was sticking on this previous regime. Now the treatment changes rapidly with the advent of these polatuzumab based regimes.
Okay. So your regimen would be Pola R-CHP.
Yeah, definitely. Based on
Yeah.
this convincing data, I can proceed.
Okay. Dr. Deepak.
Yes, yes, same. I mean, it's a high risk disease and double hit disease, so I would prefer to give if the affordability is not the concern, I would like to add polatuzumab.
Right.
And
Doc-
omitting the
Dr.
vincristine.
Bansal.
Same, sir. Pola R-CHP.
Right. Dr. Hakim.
Yeah, I will go with Pola R-CHP. Is a high risk disease, non GCB subtype. So yes, Pola R-CHP.
Okay. So all of us are doing routinely the molecular testing, the testing for double hit, BCL2, CMYC and all. Dr.
Yes,
Hakim?
we are.
Yes.
Yes, sir.
Okay. So there has been a lot of debate about the use of this regimen because this has not led to any survival benefit as of now. How convincing do you feel that you can use PFS as a landmark for selection of therapy for your patients? Dr. Arun, I would start with you.
Yes, sir. Because PFS 12 and PFS 24 is a landmark, landmark predictor for the survival for DLBCL patient. Moreover, the overall survival doesn't matter here. What I consider, because once the PFS 24 is crossed, the chance of relapse will be less, and chance of going for a salvage therapy also is going to be less. So that's my policy to choose polatuzumab in spite of not having overall survival
benefit. Right, Dr. Deepak?
Yes, same. I mean, currently we have to, be satisfied with the PFS, and because the maximum recurrence take place in the initial years only. So for if the 2 years PFS we are getting, so I mean, it's good enough to use this drug molecule.
Okay, Dr. Bansal?
Sir, I think PFS is a reliable marker in this case because not every patient will receive the second line therapy, and salvage therapies are also costly. The results are not that great. So we have to choose our best options upfront.
Dr. Hakim?
Yeah, I think the lack of difference in OS could be due to several reasons. One reason is that the data is immature, and the other reason could be there are better second line treatments available nowadays, so that could confound the results.
Right. So am I forgetting somebody who's on the panel?
Burhan is there.
Dr. Burhan. I'm sorry. So you can answer whatever you want. Do you consider PFS as a marker of surrogate marker of overall survival?
Yeah, Sandeep, I think many a times we have discussed this across the various forums, the PFS, which you yourself presented in various studies, that how PFS has been taken as a surrogate. So I am also convinced that way that the data is quite strong enough, and it is not only the PFS. We have to look for the other parameters that this trial has thrown the light has thrown into, especially the primary refractoriness of the disease that has significant, that it has declined by close to around 7%, that which I remember. And there has been another thing that significantly decrease in the requiring the second line of treatment once you are using the Polar chip. So that way, I'm convinced, and hopefully, in the times to come, we will be having more and more data as far as the OS is concerned.
Right. So I think it is very difficult to prove an overall survival benefit for patients with DLBCL. Number one, as already discussed, that there are several therapies over the lifetime of a patient. You use one line of therapy, and then subsequently CAR T cell therapy or the autologous stem cell transplant. So over a period of many years, it is very difficult to prove the overall survival benefit when you have the more stronger salvage options coming up. Number one. And number two, PFS 24 has been considered as a surrogate of overall survival in many of the studies. So before the advent of to identify the drugs which can be of therapeutic impact for such patients, there have been several endpoints, you can say surrogate endpoints defined in various malignancies. Like for CA breast, you have PCR. Now for lymphoma-based malignancies, you have PFS 24. And definitely, if you have a progression-free survival benefit, then probably the drug is gonna be of therapeutic importance. So I also believe that to prove a substantial overall benefit, one would require a longer time. And once the kind of therapies like second line therapies or the salvage therapies that they are beyond the reach of majority of the population, one should use their best foot forward and use the best regimen that is available as of now. Next slide, please. So these are about the important parameters that we see, that is clinical parameters depending on IPI scoring, imaging, molecular test, IHC, and the FISH testing. Next slide, please. So this is about the controversy, how to define and how to treat high-risk DLBCLs. We have used several chemotherapy options like SOIP, like R-Codox, MIVAC, like RDA, EPOC, and Pola-R-CHP. But considering the other regimens, that is Codex IMVAC, and which is again a very toxic regimen and a difficult regimen to handle for patients. And I think the change of chemotherapy backbone, as we have seen with other studies, has not made that therapeutic impact. Next slide, please. So preferred treatment in such patients, we all agree. We've discussed all these lines, and as of now, barring the financial, one should use Pola for their patients. Next slide, please. So this is again a very important slide because rituximab with CHOP has been the standard of care since last 2 decades, and Pola-R-CHP has been tested again with the standard line of treatment, which is, say, one of the robust regimens since last 2 to 3 decades. And you are testing that robust, challenging that robust regimen with a new drug, and it has shown that it offers you a very good progression-free survival benefit. So definitely, one should definitely go for Pola-R-CHP instead of R-CHOP for a high-risk population, like as we have discussed so far. Next slide, please. Next slide, please. So PFS, we have already covered this fact. PFS 24 can be taken as a surrogate marker for overall survival. Next slide, please. Next slide, please. So again, why PFS 24? Because majority of the patients who are actually refractory or who will relapse beyond a certain interval, that is, if you see for the trial also, there were very few patients who relapsed after 2 years. So you need some drug which is gonna have an impact early during the treatment phase. Next slide. As Dr. Burhan rightly pointed out about the primary refractoriness, which is very less with Pola-R-CHP. Again, PFS 24, we have already discussed this slide. Next slide, please. We have already discussed about the overall survival again and about the subgroup analysis also. Next slide, please. This was also highlighted by the previous speaker. who was speaking about the high IPI score and the population like ABC, elderly population. So for those kind of patients, Pola R-CHP seems to be better and scores better over the standard R-CHOP regimen. Next slide, please. So again, next slide. Elderly subgroup was also highlighted by the previous speaker that the risk of progression, relapse, or death is lower with the use of Pola R-CHP. So again, similar implications can be taken off in the elderly subgroup as compared to the standard R-CHOP regimen. Next slide, please. So this all we have discussed so far. PFS also we have discussed. Next slide, please. Next slide. ABC versus non-GCB. This has again been highlighted so far. Next slide, please. So how do you interpret the lack of difference in OS? We have discussed this so far. Next slide. And we also believe that the OS data is still immature and probably in the times to come, one might have or feel overall survival in the coming years as we use more and more patients. So this is about the real world outcome in India. This is again a multi-center real world prospective observational study with R-CHOP where you have a 2-year PFS of around 70% and a 2-year overall survival of around 80%. So this was with R-CHOP, and the similar trends we have seen in the overall in the trial, Polivy trial that we have seen. Next slide, please. So overall survival is approximately to the tune of 80 to 90%. Next slide. So what about the subsequent treatment options? I would ask this question to everyone. What do you do once your patient relapses with R-CHOP or with any regimen? What do you do? Is it the salvage chemotherapy or is it the use of referring to some higher center for autologous stem cell transplant? I don't have the transplant facility at my center. So Dr. Arun?
Yes, sir. The duration of relapse matters for me. So I'm a trained plant physician, but we don't have a setup in our institute. So mostly within 1 year, less than 1 year, I refer the patient if it is going to be a transplant candidate. If more than 24, if he relapses more than 24 months, I will take a chance for second line chemo immunotherapy, whatever available at the time standard of care. So it depends on the patient IPI, based on the previous regime, duration of relapse, and moreover the performance status and high tumor burden. That will decide my second line therapy. Usually I consider salvage chemotherapy prior transplant because it shows that if there is a chemo refractoriness, it will pick up the candidate who will be suitable for autologous stem cell. If they are not going to do well with the first line chemotherapy, then only the second line salvage regime can be tried, omitting autologous transplant or straight away put them on palliative care. This is my way of doing things.
Okay, Dr. Deepak?
Yes, I mean, again, it varies from patient to patient whether patient is autologous eligible or not. I mean, autologous eligible.
So let me put this question in a different way. How many patients in your practice they do go for transplant? If you say 1 out of 10, you can say in any number. Say for say 1 out of 10, whatever you feel like. If you are 10 patients, then probably what would be the number that are that you refer and they come back to you without transplant or that you consider for any salvage chemotherapy?
I mean, since I'm practicing for last 4.5 years, I mean, majority of my patients were, that's autologous, transplant ineligible, and majority of them are doing well with the first line of therapy. So last 5 years, I'm not referred, but in Gurgaon, we had a young patient whom we have given the salvage chemotherapy and sent to the transplantation team. So hardly out of 10, hardly 1 or 2 patients they may require transplant.
Right, Dr. Burhan.
Yeah, I think Dr. Sandeep, if you say that the percentage wise, how many are going for the salvage autologous transplant? So I will say close to around 20 to maximum 30% of going are for the transplant, not beyond.
So 2 out of 10.
So 2 out of 10 they are going. So ultimately, majority of these patients tend to receive some second line chemotherapy, And we tend to discuss the consolidation transplant, but most of the times the patients are reluctant, or they don't have the finances, or we don't have the facilities nearby for the transplant as well. So there are a number of
Exactly.
factors that play a role once we decide for the transplant.
Right. Dr. Bansal?
Majority of the patients are not fit for the transplant. In numbers, maybe 10, 15, or maximum 20%.
Right.
Otherwise, most of the patients either go for second line chemotherapy or best supportive care.
Right.
Newer options like CAR T cell are emerging, but I have no practical experience on that.
So that is the point I wanted to highlight, that majority of the patients, even in my practice, I would say 1 out of 10 will go for transplant, or would at least go to PGI and take an opinion for transplant. Otherwise, at the parent institute, patient ends up taking the salvage regimens, whether it is RIs, GDP, or whatever regimens we are using nowadays. So, Dr. Hakim, your inputs?
Yeah, actually, I am not seeing many patients who relapse. I have been practicing for the last 5-6 years. I have treated many patients of DLBCL, but I don't think I have seen many patients who relapsed.
Okay. Right. Next slide, please. So I think we all agree that majority of the patients would not be eligible for transplant, would end up using these only chemotherapy regimens. Next slide, please. So this is about the data that we have seen from China. This was another study where the prediction of 5-year overall survival with polar R-CHP was estimated. And you would be surprised to see that they use some sort of a very difficult terminology to highlight linear regression models of 2-year PFS and OS and 5-year regimen in the modern world era. And it suggested that polar R-CHP for intermediate and high risk DLBCL would improve the 5-year OS by approximately 6% as compared to the R-CHP. So maybe in the time to come, one would see overall survival benefit as well. Next slide, please. So we come to the end of the discussion. Next slide. Any concerns about the safety? I myself have used and have not faced any toxicity issues so far. I've used in 4 or 5 patients, so I have not faced any safety concerns with polar R-CHP. So anybody can comment. Dr. Singla?
Same. I didn't feel any. Addition of polatuzumab did not add it to any toxicity. No.
Right.
I have 2-3 patients currently going on, and they are tolerating very well to this addition of this new drug.
Dr. Arun?
No, sir, I had to start the account. So, moreover, I want to learn from you that what is the, IPET in all the intermediate PET in the polar R-CHP regime. Can you comment on some wisdom from your mouth or my own practice?
For intermediate, I have not used. I have used in a very difficult subgroup of population with high burden, high IPI. Any comments from the other panelists? One was c-MYC and BCL2 positive. One patient did not relapse. One patient took 1 cycle and was not fit for subsequent cycles. 3 patients are currently on treatment. So it's all a heterogeneous population, but I have not used it in intermediate risk of intermediate group of DLBCL or low risk group of DLBCL.
So what about the CMR rate, sir? Anything after 2 or 3 cycles? What's the CMR?
I think too early to comment, because all the patients have, wherever I have used, they have either completed 2 cycles or 3 cycles. One patient has completed 4 cycles, and we did a scan at approximately 2 cycles. That is for only from the academic perspective. So that patient had a huge sheath-like abdominal lymphadenopathy, and there was a sort of partial response at those sites, but too early to comment. I've not seen CMR as of now, but still with a word of caution that the patients have not completed the entire cycles.
Any tumor lysis, sir? So you are using a high
No, not at all. Not faced the issue of tumor lysis at all. Although the patient received prehydration and febuxostat,
Okay.
but not face that challenge of tumor lysis.
Okay. You use the free phase steroids prior starting polatuzumab, or what's your practice?
Yeah, absolutely. I use the pre-phased starting steroid. Actually, what we do is give a sort of, you can say, cytoreductive COP, and then manage it with the full-fledged sort of R-CHOP or PULA R-CHOP.
Okay.
So for
So
high
what-
tumor burden, I go with maybe give some sort of CVP or COP, so to prevent the complications of tumor lysis, and then challenge them with R-CHOP.
Okay, all right. What about the neutropenia and diarrhea in your own practice, sir? In 4 patients, it's manageable or
Not phased. It is manageable, although all the patients receive the prophylactic GCSF support.
okay? Thank you so much, sir. So much.
Right. Dr. Burhan, any comments on toxicity?
So as far as I have given in couple of patients, and one of the patient has completed the treatment. After 4 cycles, we assessed the patient. Patient has complete metabolic response. So that was actually that was really remarkable in that patient. The patient was around 65 years of female was there. So that was the first patient. I did not face any toxicity challenges. So patient tolerated the chemotherapy well without any neutropenias. And we tend to give some GCSF support as well. As far as the second patient was concerned, that gave only 1 cycle. After that, the patient could not continue due to finances. So the patient shifted to another area. So overall, I can say that I have not faced any challenge, and it's quite manageable. It's a manageable regimen. Yes.
Right. So I've used as in second line in 2 of my patients. One, as I told, that the patient was not fit, so it was, say, a desperate attempt from the family side also. So we referred the patient for transplant, but again, the patient wanted only chemotherapy. So we started with PULA R-CHOP, but that patient had bone marrow involvement and prolonged thrombocytopenia. So again, we had to abandon the therapy right from the cycle 2, and patient could not make it beyond a few months. So another patient I would like to share my experience, who received PULA RB and is admitted again for the 4th cycle, I think 3rd cycle or 4th cycle today. So that patient had again a relapse disease with the nodal compression on CPD with obstructive jaundice, heterogeneous involvement of the liver as well. So that patient came with a bilirubin of 11. So we gave initially, although we withheld polatuzumab for the first cycle and then added once the bilirubin was less than 3. But to my surprise, that patient is doing very well. Now he doesn't have any obstructive jaundice, and the ultrasound report was suggestive of almost a complete remission in the liver. So that patient, I'm quite hopeful that he would have a remarkable response from the POLA regimen. But the primary therapy, I think 2 patients are there that still to be reassessed or followed. So next slide, please. So that's all from my side. I think this is about the safety concerns. Next slide. How would you summarize the impact of POLARIX study on Indian patients? Next slide. We all have shared our experience in Indian settings. So this is about the second line therapy. We all know that 10 or 20% odd patients would go for transplant. Otherwise, majority of the patients end up receiving the salvage therapies. So that is why it is important to highlight and give them the best option in the right from the very beginning. Next slide. So this is about the NCCN guidelines recommended as category 1 in high IPI scores. So thank you. I thank Dr. Chitresh Rosh for providing the opportunity, and I also thank my panelists for an interactive discussion this evening. Thank you.
Thank you for a lovely discussion. I thank Dr. Sandeep and all the panelists for very, very active participation. Thank you. Thanks a lot. And I would especially thank Dr. Mukesh and Dr. Deepak for playing multiple roles in this 2-day conference. And I'm really appreciative of the contribution. Thank you.
Thank you, sir.
Thank you everyone for joining. Thank you. Good night. Technical team, please close the meeting.